A very good morning, everyone, and a very warm welcome to Foryensicon 2025, the Forensic Medicine National Conference organized by the Department of Forensic Medicine and Toxicology, Yenapaya Medical College, Yenapaya deemed to be University. It gives me immense pleasure to witness this gathering dedicated to the evolving field of forensic medicine, where science meets law and where facts illuminate justice. I am Vishnu from MBBS Phase 3, Part 1, and I'll be your host and MC for this event. We are honored to have among us distinguished guests, esteemed faculty, postgraduates, professors, and undergraduates looking forward to explore the depths of forensic medicine. Let's begin today's event with the blessings of the Almighty. May I kindly request Master Zubian Zubair to lead us. I also request everyone to please rise for the prayer.
Assalamu alaikum wa rahmatullahi wa barakatuh. Today I am going to recite Surah Ash-Sharh. A'udhu billahi minash shaytanir rajim. Bismillahir rahmanir rahim. Alam nashrah laka sadrak wa wada'na anka wizrak alladhi awqadha dhahrak ورفعنا لك ذكرك فإن مع العسر يسرا إن مع العسر يسرا فإذا فرغت فانصب وإلى ربك فارغب صدق الله العظيم.
Thank you. You may please be seated. I now welcome the dignitaries on the dais. I now request the dignitaries to occupy the stage, please. Thank you. I now take great pleasure in inviting Dr. Shyam Kishore, Professor and Head of Department of Forensic Medicine and Toxicology, the Organizing Secretary of Foryensicon 2025, to formally welcome the gathering. Good morning, everybody, and welcome to Yenapaya deemed to be University, Delakate, Mangalore. It is my privilege to welcome all of you to Foryensicon 2025 with the support of our Honorable Chancellor, Dr. Yenapaya Abdullah Kunyi, and our Honorable Pro-Chancellor, Yenapaya Farad. We are conducting this national conference, and we are happy to announce that we have got more than 160 registrations from different parts of country. We have resource persons who are experts in their field, and it will be an academic feast for the next 2 days. I would like to welcome our chief guest, our Honorable Pro-Chancellor, Dr. Shripati Rao sir. I request Dr. Musabba, our Principal of Yenapaya Medical College, to give token of our appreciation to our Honorable Pro-Chancellor sir. Memento also.
Now I would like to welcome Dr. Musabba, our beloved principal of Yanapur Medical College, to our conference. He is guiding support for all the academic endeavors which Department of Forensic Medicine as well as our entire medical college always holds. I wholeheartedly welcome you, sir. I request Dr. Kishore Kumar to hand over a token of appreciation on behalf of Foryensicon 2025. Now we also have IA from President Dr. C.B. Jani online. He could not come to our conference because of his prior engagements. Some sudden engagement popped up, but then he will join us online. And our KMC observer also is going to join us very soon, along with our guest of honor, ACP Traffic, Mrs. Najma Faruqi. I would also welcome Dr. Kishore Kumar, our organizing chairman of this conference, because even I just took over as head of department barely one and a half month back, but the idea of this conference was floated under his leadership, and he has actually led us, and we have this Foryensicon 2025 because of him. I request Dr. Venkat Krishna Shanai to hand over token of appreciation to Dr. Kishore Kumar. I also welcome our honorable co-chairperson, Dr. Veena Vaswani madam, who is known to everybody here. And again, I am sorry, I am telling this again. I always tell her experience is means my age is almost equal to her experience. That I tell her always. No, it's actually a compliment to you, madam, because she is experienced in this field, and she is here in Yanapaya since a long time. She has led this department for a long period of 18 years, and even today she is a guide to all of us. I request Venkat sir to hand over a token of gratitude to madam. I also welcome our treasurer, Dr. Venkat Krishna Shanai, who has supported the entire department again since from PG to staff now. So he has been here since long time, and he has supported us a long way. I request Dr. Allen to hand over a token of appreciation from our department to Dr. Venkat Krishna Shanai. I welcome our Vice Principal, Dr. Prakash Saldana sir, who is here, who has helped us in every step. I request Dr. Allen to hand over our token of appreciation to Dr. Prakash Saldana sir. I also welcome Dr. Abhay Nirgude, who is our Dean of Faculty of Medicine. He has also helped us in every step related to academics, and also he has advised us related to other matters also related to our department functioning and everything. I welcome you, sir. I request Dr. Allen again to hand over a token of appreciation to Dr. Abhay Nirgude. I also welcome Dr. Habib Rahman, who is our medical superintendent of Yanapaya Hospital. He is very approachable, always helping our department, because we take care of medico-legal issues. We have a CFMU functioning here, and he has always made sure that our CFMU functions smoothly. I welcome you, sir. I request Dr. Venkat to hand over the token of appreciation to Dr. Habib Rahman. I would also like to welcome few esteemed dignitaries who are here. One is my own teacher, Dr. Uday Kumar, who is also a guest speaker today. And the reason why I took forensic is because of him. Not only myself, there are at least 3 of us from my batch who have taken forensic medicine because of him, and 1 from our senior batch. And at least 3 of us are here today. So I request Dr. Kishore Kumar to hand over token of appreciation to Dr. Uday. And we also have Dr. Shahnawaz Manipadi, who is the Dean of Kanachur Institute of Medical Sciences. Despite their busy schedule, they are here. And I had the pleasure to work under him for 4 years, and it was a breeze of a time. Thank you, sir, for being here. I request our Alan to hand over token of appreciation to sir. I also welcome, yes, hello madam. Now I would like to welcome our guest of honor for today, Mrs. Najma Faruqi, ACP Traffic Mangalore, to our conference. I request Dr. Meena Vaswani to hand over token of appreciation from our department to Madam. I also welcome all the heads of departments of our various clinical as well as non-clinical departments who are here today for the function. I welcome all our delegates who are here. Without you, this academic event wouldn't have been possible. And I once again welcome you all. I hope the academic conference enriches your knowledge in these coming 2 days. Thank you.
Thank you, Dr. Shamkeshwar sir, for the heartfelt welcome. Though unable to be with us in person today, the vision and support of our esteemed Chancellor to guide and inspire us in every academic and professional pursuit at Yenapoya, we are honored to now welcome our beloved Chancellor of Yenapoya Deemed to be University, Dr. Yenapoya Abdullah Kumi, to address the gathering through a special video message.
I congratulate the Department of Forensic Medicine and Toxicology, Yenapoya Medical College, for the diligence, determination and dedication shown in organizing and conducting the national level conference Foryensicon 2025. I also place on record my deep appreciation for the progress and the transformation brought in the last 2.5. I have no doubt that this 2-day conference under the theme Medico-Legal Issue in Medical Practices will be a huge success. I congratulate the organizing chairman, Dr. Kishore, and the entire team for staging this conference with much enthusiasm. I also extend my warm wishes to all the delegates and speakers as they actively participate to enrich their knowledge and experience through this feast of learning. Thank you.
Let us now invoke the light of knowledge. I request all dignitaries to proceed for the ceremonial light lamping. Sorry, lamp lighting. I take my. Volunteers may please help the dignitaries.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च पतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य दृष्टे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Were you born between
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्म
Thank you very much, dignitaries, for lighting this moment with knowledge. I would like to call upon Dr. Veena Vaswani ma'am, organizing co-chairman of Foryensicon 2025, to address the gathering.
A very good morning, namaste. Greetings to you all from Foryensicon 2025. I welcome our Pro Vice Chancellor, our guest for today's function, Ms. Najma from Traffic and ACP ma'am, and also our Dean, our Principal and our Medical Superintendent and Hospital Superintendent, all our colleagues who have come here on this occasion as a knowledge seekers. It's been quite a reflective experience over 25 years for me in Yanepaya Medical College. When I came here, it was a one-man show. I was also the professor head in charge, and I was also from attender onwards everything. But last time when we posed for photo, we were 30 in number. So the 20 years, 25 years has been a huge experience with forensic diversifying also into ethics, clinical ethics, research ethics, forensic anthropology, toxicology in its own domain, museum which is literally called the fountain of learning. So this kind of diversification is only possible when the soil in which a seed is sown is very fertile. So I would like to thank the management for giving us such an opportunity and the sterling leadership of our Chancellor, Vice Chancellor, Pro-Chancellor and Pro-Vice Chancellor, who was then the Dean of Dental College, but he was so very encouraging in all aspects, and our Principal in a Medical College and the Dean and Medical Superintendent. You just have to take an idea for it to flourish into a huge activity. So for that I feel grateful, and more than anything, we have a solidarity with the other institutions in Mangalore itself. So the solidarity also speaks of getting together and exchanging knowledge. So I feel privileged to stand before you all and to say that today we have 2.5 decades in existence, but we still have a long way to go, but we shall do it. But often, one thing that I find we require, which we are lacking, is reflection. Why I took up ethics was also one of a momentous case decision following autopsy, when I thought what lies under the scalpel. Is it only the scalpel or an organ? Or is it a critical thinking? It's a judgment which is unbiased, which also requires wisdom and knowledge. The more you start seeking the ramification of the case you are doing, you realize we're not very adequately placed to understand everything in its true perspective. That is when I started seeking ethics, bioethics in the truest sense, and human dignity and ramification. So today I feel enriched because forensic has given a huge scope, and today's generation that is before me, I'm so hopeful that they will take the field forward in a very positive, ethical and successful way. So once again, I thank you for coming, but I welcome you all to enjoy this conference, to look around wherever you can and see whatever we have, and also give us your inputs as to how we can improve. Thank you very much.
Thank you very much, ma'am. I have the honor of inviting our chief guest, Dr. Shripati Rao sir, Vice Chancellor of Yanapaya Deemed to be University, to enlighten the gathering with his thoughts. Pro-Vice Chancellor. My apologies.
Good morning, ladies and gentlemen. Madam Najma Faruqi, guest of honor of today's function, Principal of the college Dr. Musabba, Organizing Chairman Kishore, Organizing Secretary Shyam Kishore, and all the other dignitaries, and we have the observer from KMC. Welcome to our institution. All the senior professors from the neighboring college, my own colleagues, ladies and gentlemen. Once again, on behalf of Yanapaya Deemed to be University, from Chancellor, Vice Chancellor and myself, I extend you all a very, very warm welcome to our sprawling campus here at Day1. I am extremely happy that the Department of Forensic Medicine and Toxicology, in collaboration with all their colleagues, have taken a big venture to organize this Foryensicon 2025 in our campus. Congratulations to the organizing team for taking all the pains to organize this. I know it's not a small job to organize any conference, that also at the national level. So congratulations to all of you. And the theme for this conference, national conference, is medical legal issues in medical practice. It is very much important on this present situation that everyone has to be very well versed with this, otherwise as the medical practitioners or any health seekers, it will be a big challenge if you are ignorant about this. So I think this is a very good team selected by the organizing team, and I was just seeing the various speakers who are going to address all the stalwarts from in and around Mangalore and other places. They are going to address you. You please interact with them. I am sure you will learn a lot of things from them. So they are all the most senior people in this field. Lot to gain from them, from their experience. Now, as a pro Vice Chancellor, it is my duty to at least speak few words about my own institution, the university, because many have come from outside. You should have at least a brief idea about our deemed to be university. Now, I can tell this because I am with this institution for more than 32 years, from 94 onwards. I am with this, so I am the right person who can speak about how this university has grown. I will be very, very brief, just to give an idea. In 1991, a group of philanthropists, entrepreneurs joined hands together to establish a trust called IAE, Islamic Academy of Education, with the sole motto to support and uplift the downtrodden people in education. That's the main idea of starting this. And the very result of that, in 1992, they started the Dental College. I was fortunate enough to join from the very inception almost, and continued till 2019. In 1999, the medical college was established here. Then we had the nursing and the physiotherapy college. 2008, we got the deemed to be university status. Then we never looked back. We grew by leaps and bounds. Today we have got 13 faculties. And there are 4 campuses. We have more than 17,000 students on the campus. This is the growth in the last 20 or 22 years. You can imagine how it is, because I can imagine how this campus was, a barren land. When I saw about 25 years back, the chancellor brought me and showed this campus. This is my dream campus. I asked him straight away, sir, what have you done here? We were looking at the bushy ground and all this. I was really scared. He said, he smiled and said, wait doctor, we will see later how it will be. And today you can see how we have grown. My dear colleagues, whoever has come from outside, you should find some time and go around and see some of the facilities what we have. I am sure your colleagues will tell. Especially I will request you to see the research center. It's in the same building. You can go around and see. I proudly say it's one of the finest research center. You also can go down, because as a surgeon, I am a maxillofacial surgeon, we always think about the surgical training program. We have got a center where we train for cadaveric and live animal surgical procedure, where we teach them even the robotic surgery training that's going on here. If you go to the neighboring building, we have got what we call incubation center. It's one of the most sought after center now in the country. I think we stand second, I think, if I am not wrong. And we are proud to say that we are A plus and NIRF within the 100 ranks within the country. I mean, this is in brief. And there are 2 more things you should see. One is our simulation center. I can proudly say we are the first one to implement this simulation center in the country about 12 years back, spending a huge amount, and that became a model for everyone. Now I am very happy that most of the institutions have established this. So you have to see that. And finally, there is one more center I would like all of you to go and see, is the Zuleika Cancer Hospital. My dear colleagues, Tata Trust has supported us. Today is one of the state-of-art center with all the facilities, and fortunately our Vice Chancellor is the surgeon, onco-surgeon. That's why the institution has really grown well. Now this is in brief about my institution. Let's come back to today's. I am not an expert to speak about this field, but as a surgeon I have faced certain challenges. I am not going to speak about the forensic part, but I will tell you some of the challenges what I faced during my surgical practice. See, about 5 decades back, when I was a student at KMC Manipal, those days we were not worried about these litigations and all that. What we used to have is only MLC cases, because I was heading the maxillofacial center. We used to get plenty of trauma cases, following which we have to make it an MLC, and we are made to go to the court for two reasons. One, to give evidence. Secondly, when they ask for a compensation, disability certificate will have to give. For that, I have gone to so many places. Up to Goa I have gone so many times. And when you go there, they'll just postpone the case without, considering how much time you have spent in going and coming. Sir, it is postponed, come next time. So we have undergone that. I know the hurdles of what doctors face. That was the initial period, I will tell you. That time when the public were ignorant about this. I know so many mishaps have happened during that time, but people have managed it very well without any litigations. But today, with the advent of internet and all the information what is available with a click of a button, every individual, before going to a doctor, they study about their problems, they develop their own imagination about the problem and what treatment I should seek, and then they go to the doctor, and such patients will never be satisfied. Whatever the best treatment you give, they will never be satisfied, and they start doubting that I have not been treated properly. There is some defect, or I have developed some problems after either the medical treatment or the surgical problem. They start complaining it. So this is the situation today. I know that the doctors are really facing the challenge to treat the patient. Today, earlier I remember, the senior physicians used to treat each and every case. Whatever comes to them, they used to treat, including cardiology. They were managing beautifully. Today, the minute it is a cardiac, they say, no, you go to the center. Why? Because they don't want to take a challenge and tomorrow patient challenging the doctor. They just send the patient either to a nursing home or to a medical school. So they will take the responsibility. That's what is happening. Who is the loser? Is the patient are the losers. Secondly, investigations. If you see, earlier everything was diagnosed by their clinical acumen. Earlier physicians, I remember, they never used to ask for investigation, only by auscultation, palpation. They used to diagnose and treat the patient, and they used to be happy. But today, even if they know the diagnosis, they will not take a challenge, the risk. They will ask for all the investigation and come to the same conclusion finally. Ultimately, the patients are the losers in this. Now, why I am telling is, there is so much of mistrust between the patient and the doctor that they find it difficult to treat the patient. That is the situation now. Anyway, let me come back to, I will share two of my experience as a maxillofacial surgeon. Trauma, it is very common, as I said, that we will have to go for evidence and also to give a disability certificate. But my field, we do a lot of cosmetic surgery. I'll just quote two of my experience what I had. One aerostess came with multiple injuries, referred from Bombay, because Manipal was the only center that time in southern part we used to treat. She came to me, she had multiple injuries, and to correct the jaw, I said that we will have to do some osteotomy and correct it and reset the whole jaw bones. Initially she said yes, and we operated on her. Certain areas we will have to go extraorally, and most of the things we used to manage intraorally. Unfortunately, that lady had the tendency for hypertrophic scar. Wherever we had put an incision, she developed a severe hypertrophic scar, and she was very upset. Being an aerostess, she said, I just can't go for the job. But those days we never had an idea. We asked her actually, any problem? She said, I am perfectly all right. First time she is having a skin injury and reacted so badly, and she said, I am going to sue the hospital for that. Now anyway, then we sat, discussed with her and convinced her somehow, so we escaped from the law. Then one, I am very guarded after that. Second thing I will tell you, we lost one patient. See, cosmetic surgery when you do, there should be a lot of trust from the patient side or the doctor, otherwise things will not go well. One case I still remember what happened is we operated on the upper jaw, the whole maxillary jaw was reset in a new position. Surgery went on very well. On the first night, the postgraduate called me saying that there is a profuse bleeding from the surgical side. And when I went and saw it was really severe, I immediately pushed the patient to the theatre, reopened, we downfractured again the thing, and we cauterized all the areas. From the infratemporal fossa, it was bleeding because you have got all the pterygoid venous plexus. This, and worst thing is, whenever you do these osteotomies, we give hypotensive anesthesia. So we revert it back actually. Before closure we revert it back, but it may take some time for it to flow, you see. So that time there was no bleeding, we closed it. It was, I'll tell you, a big task to handle. Somehow we controlled the bleeding, patient is all right. Second day, the patient became partly dizzy, not able to, recognize people and all that, and finally she became unconscious. And the fourth day she died of, we don't know initially, but then when they did the postmortem all that, they realized it was embolism. Clot had entered into her brain and she died. See, these are unfortunate things which can happen. Luckily, we take all this consent with the informed consent from the patient, all the possible complications written. Because of that, we are saved. And those days they were not that serious. They were convinced when we told them. But I am telling you that these are the challenges we used to face. But we could convince the patient because those days patients are much better than now. They used to have a lot of faith in the doctors and they used to accept it. But today, my dear colleagues, is a big challenge for any clinician. So please listen to all the speakers, interact with them. There are very senior faculty from Mangalore who are here. They are going to interact with you and clarify all your doubts and go back with the enriched knowledge. Have a good hospitality from our university. I am sure my colleagues will take care of all of you. God bless all of you. Thank you very much.
Thank you very much, sir, for sharing your experiences and wise words. I would also request you to release our e-souvenir for today's event. Okay. All right, sir. Thank you very much. Next, I invite our guest of honor, Mrs. Najma Farooqi, Assistant Commissioner of Police Traffic, Mangalore City, to address the gathering. Welcome you, ma'am.
A very good morning to all the ladies and gentlemen assembled here. It's my honor to be invited for a semblance of doctors, a fraternity of professors here. I thank Enapoya Medical College, Enapoya deemed to be University, Chief Patron, Dr. Enapoya Abdullah Kunu, Honorable Chancellor, Mr. Farhad Enapoya, Pro-Chancellor, and our Pro-Vice-Chancellor, Shripati Rao, the Principal, the faculties, everyone who is associated with Enapoya University, I thank you for inviting me. Foryensicon 2025. This takes me back to myself, as I'm also one of the science student, a background of science, biotech. I being a police officer, different from the profession all of you here follow, but have similarity of lines of profession based on the patients or cases. Similar to investigations that we do, doctors and professors also conduct investigations and submit reports. Coming to coordination of doctors and police, medical legal issues, one thing I would like to appreciate is how we establish a coordinated platform when it comes to movement of patients from one place to other place. Thanks to development in technology, we are able to establish a green corridor for immediate movement of organs or patients. Second thing, coming to forensics, the new laws which are in place, the Bharatiya Nyaya Samhitas, they press an important angle and perception of a forensic expert at the crime scene. So that's where forensic experts play a vital role with police officers, with the investigating agencies. Your observations and reports matter a lot. As I was saying, doctors do have to visit the courts, give their evidence, and in most of the cases, of course, a whole day is lost, most of the time traveling and most of the time waiting in the courts. That being said, if we coordinate with the local police stations, with the court PCs, probably in the first hour itself, priority might be given to the medical professors who are being produced as witnesses. I would also like to put forward certain implications that we follow in police stations. We have adopted technology in our daily life in police stations. 10 years back itself, the state of Karnataka State Police has adopted Police IT. It's a software wherein we enter day in, day out all cases into this platform. Similar way, Ministry of Road Transport has also started a platform called IRAD, which has developed into EDR. It collects all the details regarding the road accidents. This happens on situation basis based on the complaints coming in. They immediately unfold themselves. Here, as we know, we receive an MLC from the hospitals, and that MLC is being taken as the first report from the hospital regarding the patient or the incident which has happened, road incident. So of late, when IRAD and EDR are in place, we have been instructed by NIC and MORTH that any MLC received from the hospital must compulsorily come in IRAD format only. So I take this advantage of this platform to inform all the hospitals to send the MLCs through email along with the IRAD form in which the patient details are written. Being into the profession of police and recently getting into traffic, I have observed when we receive an MLC, most of the doctors, they hold themselves back from actually writing what the incident was and just mentioning it as an RTA. Though there are instances that the patient wouldn't have even been in the position of moving in the moving vehicle. The vehicle would be on a standby. Patient was about to get down. Meanwhile, he falls, and still it becomes an RTA. So there are two things in this, whether it was a road traffic accident or a road traffic incident. I would urge all doctors to specifically note what the complainant is giving you. Obviously, you would go by what the complaint is received. Further, after post-mortem, we would get the detailed report. Of late, there are also reports from forensic experts saying after the PM report is submitted, we would give a final report. So there are these obstacles where you have to talk with the concerned investigating officer or the agency and clarify your doubts of what has happened, how it has turned out to be. Because most of the times you have always, a coin has two sides. A complaint has always two sides, and that's the reason investigation comes into place. So this is where we as police officers come in contact with doctors, and both of us together play a very important role, especially in terms of those cases wherein road traffic accidents have occurred, or it may be the POCSO cases and the murder cases, the body offense cases, wherein we come with each other. Saying this, if there are any doubts which could be raised and I could clarify on, I would be happy to, or else I would close it. Yeah.
So some reviews here in CFMU of our district. How much role does our history play? Because sometimes police sometimes request us. The history what we have given is hit and fall. But then from your investigation it comes, you come to know that it was a collision by two vehicles.
Yes.
So sometimes we get a request to change the history also, but I kind of
See, because, see, I'll let you know about this. What happens is, if a person skids and falls, the insurance claimed is much higher. So what does the complainant do? They go and give a complaint, we had a skid and fall. Though there would have been an accident or something else. Later, on investigation, because of the CCTV cameras, we come to know that it was not a skid and fall. So that's the reason we would come back to you stating so. So this is where the insurance also plays a vital role, how you claim it, and public has good knowledge about it.
what if the doctors restrict themselves writing only alleged history of RTA and leave to the police to the reasons like their report?
That is what is happening right now, sir.
So even we have noticed that even we mention the vehicle, so we write a Jeep or some bike or car, and next it comes it's no, it's a Bolero or something.
That wouldn't matter, sir.
Safely we restrict ourselves by
Alleged writing of, RTA history would do good, but if the complainant mentions you that certain vehicle has it, probably you will have to mention it. That's how it goes.
I have queried. Two persons are riding in a two-wheeler. The previous rider gets chest pain. Even the other person has chest pain. By the time he stops, he falls sudden collapse. Is it RTA or what are these tests?
So what happens is, again, based on the complaint, you will be writing it. If he would say that he had complained of a chest pain, probably you will write down it as a chest pain. But when he falls, he gets hit by the road. So if he only had a chest pain and if he was sitting at home, it would have been a different issue. Because of the fall, if there is some internal damage, then again PM matters.
Should the doctor be scrutinized for that?
It's not actually scrutiny of the doctor. It's you can say, as our Pro Vice Chancellor was saying, the way doctors used to clinically diagnose the patients earlier, today they don't have that strength. It's not about scrutiny. It's about how well you can scrutinize your patient. That's it.
Yes, ma'am. Thank you.
Yeah, with this, with kind permission, I would like to close. I hope my words helped you out. Any queries, I can get back to you on that. Thank you so much. I thank all the esteemed dignitaries on stage for allowing me to give a 2-word speech. Thank you so much. Thank you, everyone.
Ma'am, I would also request you to release our e-souvenir for today's event.
This one? Congratulations. That's it? Yes? With this, I would also like to add something. This is completely a traffic angle. How many of you are from Bangalore? Presently, there are AI cameras in place across the city. I forgot about that. Unfortunately, we have certain traffic violators who happen to be from certain professional backgrounds, and we being from such profession should be avoiding violations in traffic, especially seat belts, using mobiles. I understand doctors are on emergency calls, and I receive such messages saying I was on the emergency call. But then again, kindly park your car while you're on call. Wear seat belts. As being professionals, we are humans at last. Yeah? Thank you so much.
Thank you very much, ma'am, for sharing your thoughts and enlightening the audience. I would humbly request Dr. Shyam Kishore sir to felicitate our KMC observer, Dr. Vishal Kolhapur, with a certificate and memento. Thank you, sir. I would like to welcome our principal of Yanapaya Medical College, Dr. M.S. Musaba sir, to share his valuable insights.
Good morning to all of you. I heartily welcome you, all of you, on the behalf of Yanapaya Medical College to this national conference, medico-legal issues in medical practice. Honorable Vice Chancellor Dr. Shivati Rao, Guest of Honor Mrs. Najma Farooqui, Dr. Shyam Kishore, Professor and HOD of the Forensic Medicine and Toxicology, Dr. Kishore Kumar, Dr. Veena Vaswani, Dr. Venkata Krishna Shnai, KMC Observer Vishal, all the HODs of all the various HODs of the Forensic Medicine and all the other departments, and respected Principal of Kanachur Medical College, Dr. Shanavas Manipadi. This conference is one of the very important conference because it is a national conference, and medico-legal issues is I was facing a medico-legal issue. I was working as a government doctor in Calicut Medical College. I think I am proudly say that I was one of the men who attended the court maximum. I am very because it is mainly because of a traffic accident in Calicut Medical College. Sometimes 2 or 3 buses came together after collision, and we have to write I was working during that time as a lecturer after MS. You have to write it every day, every what it will be, let it be a major accident, let it be a minor injuries. We have to write the case, write the certificate. There are two certificates in MLC. That is, one is the wound certificate, and the most of the cases, in the minor cases, wound certificate is enough at the time of the observation when the patient is brought to the casualty. If he gets admitted, then we have to discharge certificate. The wound certificate, usually it is what is the documentation is very important. In the court of law, we are questioned when the documentation, as the madam said, the documentation, how the first impression is the best impression. First what they are telling that it is the first, then let them change it later. But what the first they are telling, we have to record it. If it is RTA, it is this one. What is the type of RTA? It is all the wound certificate. I am sure it is not much changed. This one, wound certificate, and there is identification of the victim. We have to. The most of the medical the doctors, they are not writing the identification marks, and if possible this one, what is the age of the wounds, when it occurred, it is immediate on, or it is occurred 1 day or 2 days before. We have to this one, we have to record it. And in the court of law, especially in the assault, the lawyers are asking everything. That is this wound be produced by this weapon? Okay. This instrument. Okay. Well, everything is. Ultimately, we are fed up, and ultimately, when I used to tell, then he asked, which wound, this one weapons, it will not be produced. I used to tell, I was carrying this wound certificate. If it is written by this paper, it will not occur. that is what is the defense lawyer is also bribing they are turning the event. So you have to be very careful when you are going the court of law. And our statement, medical legal expert statement, is sometimes crucial in determining the ultimate this one, what is the result of the medical legal cases. Very much. There are several incidents because of the outcome is changed only because of the statement of the doctors. So we have to be very careful. We have to be very sure. We have to always help the prosecution, and should not take it as lightly in recording these medical legal issues. With these words, I express my gratitude for inviting me to this conference. I wish you all the best. Thank you. Thank you all.
Thank you very much, sir, for your wise words and sharing your experiences. I now call upon Dr. Kishore Kumar, Professor, Organizing Chairman of Foryensicon 2025, to address the gathering. Welcome, sir.
Hello. Respected dignitaries on the dais and off the dais, and my dear friends and delegates. I am so happy here, all are here. The delegates are my friends. I am using this platform to mention the two things. One thing is, one respected, our Ramachandran sir was here. When I joined here, there is a small incident happened. In the 2003, when I am studying in Calicut Medical College, the two police officer came and asking one file. At the time, Shirley madam was an HOD. File was missing in that, That time, Madam called Ramachandra sir. Sir was here as a principal. Sir told that that file is there in that rack. We took that file. That file is something related to Munna. When the file was taken from that, immediately is taken by that police officer, they told that they are from CBI. Actually, you don't know what is there in that file. And after that, I told I am joining here. Sir was very good with us. After certain days, there are two police officers came here and asked that, with this certificate, they told that we are from the police department. We want an opinion from regarding this case. Cause of that, it's like burns. So they asked one question, whether it's an antemortem or postmortem. Sir didn't touch anything, Then they told that we are from the CBI. By the time, they came to our department and they searched almost all the cupboards, seeing that is there any money was there. That's one thing. In that, Munna murder case, sir was tortured by, sir was always saying that, that Burns case is the safest one. But from that case, it is an eye-opener for us. Second thing, and thanks, all, because Krishnan, Ajay, all are my friends. Second, one more things, I tell sir, because they are my classmates. One more thing, I want to mention here is, this is my dream. Actually, you actually plan to conduct a conference in the 2019. Our bad luck, after the COVID, it turned to a virtual platform. So we bid so many conferences, but we didn't get. So with the help of Mabali Shetty and Uday sir, actually we plan to start an organization here. It's called as an CAFME. Because of some of the ego problems of the Mangalore, it was spoiled. Still I am requesting, Mabali Shetty and Uday sir or Shankar Bakkan or Hari sir, again we have to start that one. Because when we started that, actually the name was that one. So later we didn't have any supporting other organization for us. We didn't request it also. So that's the second matter. Having said that, thanks for patience listening.
Thank you very much, sir. To express our most sincere gratitude, I invite Dr. Venkat Krishna Shenoy to deliver the vote of thanks.
A very good morning. I would like to take this opportunity to propose the vote of thanks. I extend my gratitude to our Chief Patron Dr. Yenappa Abdullah Kurni, our Honorable Chancellor, Yenappa deemed to be University. His vision and support have been fundamental to this institution and its endeavors, including this conference. My sincere thanks to Mr. Farad Yenappa, who is the Pro-Chancellor of our university, for his encouragement. And my deepest appreciation to our Chief Guest, Dr. B.H. Sripati Rao, Pro-Vice Chancellor of Yenappa deemed to be University. He has set an intellectual tone for the sessions. His insights reflect the university's commitment to advancing knowledge in this field. Presence of guest of honor Ms. Najma Farooqui, ACP Traffic, Mangalore City, is especially appreciated. Her participation highlights the intersection of forensic aspects and law enforcement, emphasizing collaborations between the fields to achieve justice and ensure public safety. Gratitude is also extended to the organizing committee and the faculty, residents and staff of Department of Forensic Medicine, Toxicology for their efforts in bringing Foryensicon 2025. Thanks also to Dr. M.S. Musaba, Principal of Medical College, for his support and leadership. Appreciation goes to Dr. Prakash Saldana and Dr. Abhay Nirugade in their respective fields. I also thank Dr. Ashwin Datta, who is Dean of Academics, in his absence. Finally, to all the delegates and participants, thank you for your enthusiasm and presence, which promise to make this conference engaging and enriching. The anticipation is insightful deliberations and networking in these 2 days. Thank you once again for attending this inaugural ceremony. Have a rewarding conference. Thank you one and all.
Thank you very much, sir, for your kind words of appreciation and gratitude. With this, we now conclude the inaugural ceremony. Thank you very much. I request our delegates to kindly be seated. We'll be starting, the session will start soon. I request the delegates, our first session starts now. Our first session is starting now. Sir, we'll tell volunteers. I take great pleasure in inviting Dr. Ajay Balachandra, Professor of Department of Forensic Medicine and Toxicology, Amrita Institute of Medical College, Amrita Institute of Medical Sciences, Cochin, and Dr. Nasir Ahmed, Associate Professor of Forensic Anthropology, Department of Forensic Medicine and Toxicology, Yanapaya Medical College. I request Dr. Ajay Balachandra, Professor of Forensic Medicine and Toxicology from Amrita Institute of Medical Sciences, Cochin, to join us for chairing this session. I take pleasure in inviting Dr. C.B. Jani, who could not join us today and will be here through an online session. He is a professor and head of Department of Forensic Medicine and Toxicology from SAL Institute of Medical Sciences, Ahmedabad.
A very good morning to all of you, and it is my pleasure to introduce our C.B. Jani sir, who is IFM president, and he was professor and head of Forensic Medicine and Toxicology, SAL Institute of Medical Sciences, Ahmedabad. He has finished his MBBS from Saurashtra University, MD Pathology from Saurashtra Rajkot, Forensic Medicine from same university, and DNB in Forensic Medicine NBE. He is LLB and Super Special Sardar Patel University Anand. Sir is going to talk on the topic challenges faced by a medical practitioner pertaining to medical negligence. And it is our privilege, sir, that you have joined, even you have so much of engagements, and it is a little bit of delayed from our side, but I hope that in future you will come in person and meet us. And now I am handing that dice to you to address and with your guest talk. We welcome you, sir. I welcome Ajay sir to come on the side. Jani sir, please. Volume.
Yeah. Good morning, esteemed delegates and all participants. At the outset, it's my pleasure to be part of this excellent academic fiesta. Unfortunately, I couldn't make it out in physical mode. My sincere thanks to Dr. Veena Vaswani Madam, Dr. Kishore Kumar sir, and Dr. Nasir sir for giving me this opportunity to share my views on challenges faced by medical practitioners pertaining to medical negligence. The theme itself is quite unique, that the dynamics of medical practice across the country, they are changing very fast. Probably many times the pace with the legal needs or requirements or problems, those are, you can say, little bit challenging as well. I will not go into detail of various authorities, or you can say judgments of High Court and Supreme Court or Consumer Court, but we'll try to briefly articulate the relevant points where the medical practitioner face some problem or challenge, and those area, you can say weak area or vulnerable area, need to be focused by practitioner. Not citing the judgments by various courts, the reason is their legal appealing system also is having dynamic. There is one judgment by a state consumer forum, then it is either upheld or it is reverted by National Commission, and so the case with Honorable High Court and Honorable Supreme Court. But by and large, the ambit of present talk, there are the salient points. First point is qualification, registration and scope of service. The medical qualification obtained by any person, that shall be the governing or dictating foundation with reference to medical practice. Practically, if you see, there is overlapping in many practices. Like, let us go for the hair transplant, whether a dermatologist can do or whether a cosmetic or plastic surgeon can do. So basically, whatever qualification awarded by medical council, the PG curriculum or postgraduate or undergraduate curriculum, that shall be the sole criteria whether the person's qualification allow him or her to undertake a particular diagnostic or therapeutic modality or not. The challenging part many times that is diploma and degree. Somebody having diploma qualification and another person having MD or MS qualification, that is also crucial. Many times there are issues where it is alleged that the registered medical practitioner has acted beyond his jurisdiction, or you can say his or her ambit. Registration, that is with the state council or even the clinic, we can say that is mandatory, and whatever registration is there, suppose somebody is having MBBS degree which is recognized and the postgraduate degree which is not recognized, so the registration with council, state council or national commission, that will be based on MBBS. So in other words, he is authorized to practice only at the MBBS level. I give you my example. I am MD pathology also, I am MD forensic medicine also. I have both registration with Gujarat Medical Council. So does it mean that I can start a pathology laboratory also and I can work in forensic medicine also? Answer is probably no, right? Because out of various branches, one has to be very clear and categorical that what sort of qualification is being used and that is being catered services to the client or the patient. The scope of service collectively, that will be defined by this basic thing, that is qualification and registration, and this is the major area where the foundation, or you can say the inception of patient-physician relationship, that is a sort of fiduciary relationship, and it is desirable that the things in form of qualification, expertise, that shall be crystal clear to the patient party, so later on there are no disputes. Few cases are there where homeopathic or Ayurvedic doctor, they have treated patient and there are some complications, and basic thing, the registration or the scope of service that is challenged based on the qualification. When patient approaches the second part, whether to accept that patient or to refer it, that also is very crucial, very challenging, because commercialization of medical practice, or you can say the financial aspects of establishing medical setup, that also matters. So straight away, theoretically we can say that yes, patient shall be referred, but that is also equally dangerous. When to accept, when to refer. If the registered medical practitioner feels that his qualification permits him to examine that patient and to reach to the provisional diagnosis, if it is not diagnosed earlier, then on the basis of that, he shall decide that what are the diagnostic modalities which may be required, and after interpretation of those analytical or investigation reports or results, whether he himself or herself can manage the patient or needs referral to some other specialist or some other center. At this juncture, it is very crucial whether the case or the patient, whether it is a hot case or cold case. This is applicable in case of cold case only. Hot case, that is emergency, we are bound by Pandit Parmanand Katara versus Union of India Supreme Court judgment guidelines, that the emergency treatment must be given to the patient, and making him little stable, the registered medical practitioner shall ensure that it reaches the safe hands to the tertiary or higher center. Cold case, yes, you have option, right? Many times telephonic contact is, or telephonic consultation is done by WhatsApp or calling, right? And even on holidays or Sundays, or you can say after office hours. So when you are saying that when to accept a cold case, the clinic shall be very clear that what are the consulting hours or what are the visiting hours. This does not mean that one is not to be remain available for emergency services. So this is very crucial, specifically with reference to obstetricians, where the antenatal follow-up patient visits gynecologist or obstetricians many times, and we never know where some complication of pregnancy or where some birth process will start. So this is best example combination of both. Doctor has been examining, has been consulting the pregnant mother in recent past at many occasions frequently, and at the 11th hour presence with some emergency situation. So most common issue in medical practice is with obstetricians. If you see the recent judgment by Allahabad High Court in one of such cases, the doctor approached High Court for quashing of FIR against him, and unfortunately High Court denied that no, the FIR cannot be quashed because there is strong prima facie. There are certain other aspects also in those cases. Past history is the next area which is very crucial, because material suppression of the previous illness or previous health status or previous medication, that is very crucial. Many times patient or patient relatives either fail to communicate properly or deliberately they suppress the past history. So how to retrieve relevant past history, that is also an art that we have been taught during our UG days, undergraduate days, ODP, origin, duration and progress. Based on that, the medical history about illness, medication, surgery and so on, those should be retrieved. If you see the OPD case papers of some hospitals, or even you can say the emergency room where the history is written, many times it is very incomplete and vague. History of RTA at around so and so, that's it. Right? Later on, after 2 days, case turned out to be non-RTA case or some other thing. So it is very crucial to document. In the inauguration ceremony only, one of the dignitary on dais mentioned importance of documentation. So what is the source of retrieving your past history? That should be clear. Otherwise, when in future the history given by the relative is disputed, the version of the treating doctor is very crucial. So one must be very clear that what is the source. Not simple by patient relative. Who is relative? Whether attendant or wife, husband, son, whatever is there. Even the name has to be mentioned in that. I have seen a few medical records which are very wonderful, that they write down on the page of outdoor ticket that above history is given by so and so, and the signature of that person with name, that is also documented. So this is a wonderful thing. So this leaves no possibility or no chance of any debate or dispute with reference to history retrieved by the doctor. Second thing, many times the doctor comes across a patient presenting with some complication of some treatment given by some other doctor or other hospital. Right? And you are managing complications of the previous treatment, maybe in recent past or remote past. Why it is crucial? Because if there is some litigation against that doctor, the lawyers will advise them to make the subsequent doctor also party. So, though the component of allegation of medical negligence may not be there, for the second or subsequent treating doctor, but the legal requirement, that is proper joinder of the parties or opponents, the majority of the advocates suggest that, okay, starting from 1 to 10, all shall be male party. Let them put up their case. So if we are not clear, then many times as a party also we know that what previous history was there, what was the recourse, what was the outcome, what were the complications. Now complications of previous surgery, many interpret as risks provocateur, that the thing speaks for itself. Meaning whereby we are writing down complications, that so and so these are the infection or sepsis, whatever we write down, right? So straight away they will be articulating two things. One is the surgical modality or the therapeutic modality in presenting complication. That it has complicated, it means there is negligence. So we have to be very cautious in such cases, and that is why the importance of past history, past medical status, health status, that is very crucial. The infrastructure and availability of resources. Infrastructure facilities, if we have some facility which is required for diagnosis or treatment of that particular patient, or there are chances that it may require. Suppose patient is in ICU, right? But ventilator is not functioning. Let us presume just hypothetical situation, right? So that is also infrastructure in terms of equipments. So that also shall be kept in mind. Availability of resources. When we say resources, that includes plenty of things. Your paramedical staff, nursing staff, ancillary staff. If you are planning for some surgical intervention, whether anesthetist on call will be available or not, or many times if the surgery is likely to have some complication in terms of hemorrhage, whether the blood bank in near vicinity is available for the blood component or not. I had one practical exposure to one such case, now where the gynecologist tried to save the patient, and it usually takes 1 hour for procuring the compatible blood component. So in that case, the authority, I will not name the authority, still matter is sub judice, they said that if you don't have the in-house blood bank facility, you should have not taken this patient. So these are the debatable, you can say, area whether whatever resources you will have, those are at what response or reaction time. That is very crucial. Other things, like suppose there is some complication, right? Some surgical complication, again giving the example of obstetrician, if there is accidental cut of uterine artery, whether the gynecologist is skilled to perform internal ligation, or any other gynecologist in near vicinity who is available, that if so and so complication occurs, he will be responding or attending the patient in so much of time. So many things of present scenario, few things in anticipation of some untoward, undesirable event or complications. Because legal contention is that complications can occur, but whether you anticipated that, whether you are prepared for that, whether you diagnose the complication timely and try to manage that, those are the disputed areas. Choice of diagnostic modality. There is much advancement in the imaging technologies, CT scan, MRI, contrast, this, that. Here it is very crucial that the treating doctor should prescribe a particular diagnostic modality in the interest of diagnosis, not in the interest of or considering the factors like remoteness,
I think we will wait for the technical issue to get resolved. Yeah.
sincere regrets for some connectivity issues. So, sorry for interruption. Again, I will have to redo a few things.
Please continue, sir. We already lost you for some time.
Sincere regrets for some technical hindrances at my end. So, diagnostic modality, that is also very crucial. Whether, host, am I audible?
Yes, sir, you're audible.
Yeah, fine. So, whether it is invasive, whether it is non-invasive, invasive means angio-contrast, CT or contrast angiographies, where the dye also is a factor. So that is very crucial, and mere explanation to patient or patient relatives may not be sufficient, but if we as a medical practitioner should be able to assess the risk and benefit ratio in a particular given setup or with reference to particular health status of the patient. The second part, that is the choice of therapeutic modalities. Now, therapeutic modalities basically depend on three things. One is the clinical findings, second is the radiological investigations, or third is the pathological or laboratory investigations. So, which therapeutic modalities, whether medical or surgical, that is basically very crucial decision making. If you see the majority of the CT scan or MRI reports nowadays, the radiologists also, they go very defensive. They write down that clinical correlation is required, right? There are, in CT scan, the lesion is reported, may be reported as malignancy or non-malignancy, and later on, at surgery or surgical exploration, it may turn out to be totally different thing, and that adds to the surprise and agony of the patient, and at the same time, little bit problematic thing for the treating doctor. So, therapeutic modality, again, what type of medical management, surgical management, suppose somebody is physician and he feels that the surgical modality will be more appropriate rather than the medical management, but still, till the surgical modality is executed, for time being some medical management is necessary. So those aspects are also equally important. In case of surgical modality, now we have minimally invasive surgeries and exploration also. So risk benefit ratio in both, that is also very crucial. Nothing is free of complication. If somebody says that a particular procedure is free of complication, either he doesn't know that procedure or either he is lying. Right? No treating doctor can assure that there will be no chance of complication. Complication, if you go to the standard textbook of various medical specialties, the procedures are full of complications. And at the same time, they recommend what precautions and early and timely diagnosis of those complications as well. So, just to secure the patient that gets operated at your hospital or clinic, the pseudo assurance or the fake assurance or over assurance, that is also quite risky. And by and large, the complications shall be conveyed. There are various judgments where it is written that the complications having 10% probability shall be communicated, 10% and above. Now what is the 10% figure? 10% of which complications? All complications or the complications faced by a particular doctor or particular hospital. So better is whatever professional experience the treating doctor is having during his professional career with reference to a particular procedure, whatever common complications he encountered or witnessed and successfully managed, those shall be kept in mind, not the complications written in the book, anything possible. We see blanket, very exhaustive consent forms where even for short DA they write down that on-table death is possible. Now, technically fine, right? But if in short GN minor procedure like insertion of fixation of external fixation of radius or ulnar fracture with K-wire, if it's write down the on-table death possibility, it will be a little scary to the patient as well and relatives as well, and I don't think that they will be consenting. On the contrary, they will feel that doctor is not confident and so on. Second thing, when we say multidisciplinary approach, physician, consulting nephrologist, referring or inviting nephrologist or hepatologist for particular case, whatever advice that person gives, suppose a patient of ARF is being managed by physician, he refers or calls nephrologist, he advises dialysis, SOS. In that situation, either the treating doctor shall refer that patient to a hospital where the dialysis facilities are available. He cannot keep the patient with him and do not do dialysis and be hopeful that with replacement therapy patient will improve. Hopeful thinking, wishful thinking is always good, but in real life hardly happens. If the patient himself or herself is not ready for such aggressive or higher line of treatment, that should be reduced to writing that the patient or the relatives, they are not ready for that. Now when we say relatives, it is very crucial that why we don't explain or why don't we take consent of patient. Later on we said that patient was semi-conscious, so better write down Glasgow Coma Scale, patient is, what is AVM response out of 15, and write down that since this consciousness level is not satisfactory to procure consent, the relative has been contacted for consent as an authorized representative of the patient. Because conveniently we cannot say that here we will take consent of patient, here we will take consent of patient relatives, and here we will take consent of both. If we are not taking consent of patient, we should be clear that his composed mentis or health status is not sufficient enough where he can exercise his critical decision making and communicate. So that is about communication and consent. Nowadays, the next part, the State Medical Council, Consumer Court and Criminal Court. It is very common. In case of death on table, the relatives, they ask for post-mortem examination, make a case police case, later on with opinion of medical board that charge of criminal negligence, that is whether sustainable or not, that will be decided. But here what happens, I have seen that in few cases there are parallel complaints. One complaint to the medical council, state medical council obviously, another complaint in the consumer forum, another criminal case against doctor. Now here the criteria for criminal medical negligence are different and consumer or civil negligence are different. So the investigation papers or documents of criminal investigation, those are used in consumer case, which is very risky, and cross-examination of those records are also not possible. So it is very crucial that if the criminal case is there, one has to be very extra cautious that how it will be used or misused by the complainant or by a opponent in the consumer case. So far as state medical council is concerned, with respect to all office bearers of various state councils, whenever some complaint or case is referred to them for opinion of medical negligence, I doubt whether they exercise objectively whether their opinion is about civil negligence or criminal negligence. Conveniently one may say that it is referred by police, so it is criminal negligence. That's fine. I do agree to that interpretation and contention, but still, whatever opinion we say, that there is no component of medical negligence of criminal nature, or there is component of medical negligence of criminal nature. That much clarity also is lacking at majority of the places, and those opinion or strictures by the medical councils are also used by the complainants in the consumer cases or even in the criminal cases. So it should not be left to the interpretation whether it is civil or criminal case, but rather the medical board who is opining about medical negligence, they shall be also making it more clear whether their opinion refers to civil negligence or their opinion refers to criminal negligence. If it refers, because doctrines of both are different. Doctrines, majority of forensic medicine persons here, Dr. Ullas Shetty, Dr. Kishore sir, Ullas Shetty sir, I saw you, that's why I am naming you. But I heard Marvelous sir and Suresh Shetty are also there, Dr. Suresh Shetty also there. See, doctrine or criteria for civil and criminal negligence are different. So if the criteria are different, we cannot, or you can say the medical board shall not be allowing open interpretation that it can be suitable to any of them. They also shall try to specify whether they are opining about what type of negligence, civil or criminal. The last point, that is catchment of the higher center. Why this is important? Suppose I am in Ahmedabad being medical hub, patients across Gujarat state comes to hospitals here, even the neighboring states, border districts, they come here. So that is, you can say, catchment. Why this is crucial? The Consumer Protection Act amendment that has expanded the jurisdiction of the complainant, meaning thereby, let us understand the example, a patient residing in South Rajasthan coming to Ahmedabad, Gujarat for medical treatment, if there are some complications, now the new amendment in 2019 that allows complainant to file the case in the South district of Rajasthan. So catchment also is very crucial. We should keep in mind that whether we will be able to tackle the situation if there are some legal complications or not. I think with this, I conclude my views here. Thank you very much for patience listening, and with permission of Chair, I will try my level best to respond to few of queries from the esteemed audience. Thank you, sir.
Thank you, Dr. Jani, for that erudite and very detailed talk on the subject. I could see that you were actually talking about the matter without going into the basis or judicial verdicts and other things which form the basis behind that. That would be going into too much detail, I think. One thing I noticed was that your reference to that 10% of complication which comes, I think, in that Samira Kohli verdict, where the contrast is between real consent and informed consent. One thing I noticed, which I wanted to say, actually, not what I noticed, is something which was being discussed in Kerala medical legal community some time back regarding a High Court verdict from Kerala. We have a process of deciding whether a doctor can be proceeded against in a criminal negligence case. That process is there. That process has been sort of disrupted by a single judge verdict, where the judge has ruled that a doctor should be heard, personally heard, before the committee which is constituted in the state. There are regional committees. Whether they decide whether that can be that case can be considered as a criminal case, criminal negligence case. So, any thought on that, sir?
The very relevant and pertinent thing. See, our judicial system is based on principle of natural justice. Whenever a person is to be charged criminally or even civil case, the opportunity of being heard, that is very mandatory. Now, opportunity of being heard before medical board, that also is very crucial. Rather, the medical board shall decide the issues, that what are the issues which need to be further explained by the treating doctor. Suppose, if you see the medical record sitting in the office, right, if you don't consider that whether the center is underserved area where the resources may be limited, that is one factor, right? It's simple that there is hemorrhage, immediately we should infuse or transfuse compatible blood component. But practically it may not be that easy to implement even for us if we are in that situation. So it is obviously very pertinent point that the doctor against whom the charge has been labelled shall be given an opportunity of being heard or presentation or clarification before the committee till the committee forms or frames an opinion. That is my personal view.
Thank you, sir. Any questions from the audience?
Any questions, any reflections? So I think all the things, yeah.
It will be audible, right? It will. I'm a clinician. I'm Dr. Balchandra. My question is, say a patient is very anxious of a procedure and he is diagnosed with like MI, and if you directly tell that he is having such a life-threatening disease and he is not willing to undergo a procedure like stenting, can we take consent from the relatives, or should we always take consent from the patient?
Yeah, very pertinent question. See, when the legal validity of a valid consent or legal reliance of a valid consent, that it has 7 components, it should be free, it should be clear, It should be free from false fear, portion misconception. Now here the crucial part, if you feel that patient is in condition where he is not in a position to exercise his choice of undergoing something or not undergoing something, then only comes the question of patient relatives, right? If patient is, like suppose patient of MI is in mild, you can say, the drowsy state, right? Then in that case, his or her consent is not material, the consent of relatives only are material. So far as the decision making of a completely mentally stable patient is concerned, first of all, it is his or her choice only from whom the communication shall be done in presence of relatives, and consent has to be obtained by the patient source only. If patient is medically unfit to understand the consequences, then only the consent or the question of consent from relatives that arises. That is my personal view, sir. Thank you.
Sir, one more question I want to ask. Say patient is having seropositive status like HIV. Now he does not want it to be revealed to anybody, including his spouse. In such a condition, say he develops any life-threatening disease while on treatment or on when he is undergoing the treatment in hospital. So what should the doctor do?
Well, so far as the HIV status is concerned, majority of the state, they have societies, National AIDS Control Societies and their branches. And now the counseling part is very streamlined, right? You have to refer the patient once he is HIV seropositive. Even you can say somebody is blood donor, incidental finding, you find that the donor is HIV positive. In that case, it is our duty to refer to the nearest counseling center approved by government for the purpose of counseling. And they have clear objectively structured part on this, that what are the family members counseling part is and consent log from the patient part is there. Long back, one hospital from south, I will not name that, disclosed the HIV status of a doctor patient to the spouse or the spousal side, and that matter went up to Supreme Court also, and where the right of privacy, that was major contention by that doctor patient. So in that case, the view of court was that the right of privacy is not with only one person. The rights are with everybody. Even the spouse has right to know. So whenever there is conflict of rights of few persons with reference to particular situation, it has to be weighed in the medical interest only. So just to sum up, the counseling part, information to near relative, that is very crucial, and that has to be done in presence of patient and the relative, and in a very cordial way. Not earlier the HIV part, that was, you can say, taken as social taboo and so on, but now those things are not that frequent, and the state AIDS control society or the city or district level AIDS control society, they are having counseling centers for that, and even the reporting part also is mandatory, that people living with HIV and AIDS, guidelines are very clear about that, so that has to be followed.
Because of the lack of time, actually, you can post your questions. We will share it to sir, and he is very active to respond, and he is also giving consultancies, medical legal consultancies to hospitals, individuals. He always go with the prosecution as well as the defense. So there are so many questions, sir, so we will post you, and I hope that you will get back. And because your presentation was covered from the dilemma to the qualification, followed by that this therapeutic diagnostic modality and juridical. So with this, we would like to thank on the behalf of our organizing team and from our Yenapa University to spare your precious time with us. And with this, we would like to thank you. And we have your mementos and certificates just to show you as a token of love. And we will post it to you, sir. And we hope, because this last moment of your busyness, you didn't come in person. So thanks to you. And I hope it is visible. We are giving on your behalf to sir. Okay, sir. Yeah, on his behalf. So, thank you, sir.
Yeah, welcome. Thank you. So nice of
I request Dr. Shyam Kishore sir to felicitate the chairpersons with a memento and a certificate. Thank you very much, sir. Now I would like to welcome Dr. Harish Gowda, Professor and HOD of Department of Forensic Medicine and Toxicology from Father Muller Medical College, and Dr. Kishore Kumar, Professor, Department of Forensic Medicine and Toxicology, Yanapaya Medical College, to join the session as the chairpersons. We welcome you, sir.
Thank you. Good morning. Okay.
I would now welcome Dr. Uday Kumar, Medical Superintendent and Professor in the Department of Forensic Medicine and Toxicology from Father Muller Medical College, Mangalore, as a guest speaker. We welcome you, sir.
So, good morning. Thank you, ma'am. This is my privilege to introduce today's guest speaker for the next session, Dr. Uday Kumar, sir. So, he is the senior most forensic expert of Dakshina Kannada. And Dakshina Kannada, everyone knows about sir, and even forensic colleagues from Kerala also will be knowing. Just a brief introduction regarding sir. So, Sir is presently, he is a medical superintendent of Father Muller Medical College Hospital, as well as professor of Department of Forensic Medicine at Father Muller Medical College. Sir has completed his MBBS from Government Medical College, Ballari, and Gulbarga University, and MD in Forensic Medicine from Kasturba Medical College, Manipal, Mangalore. Sir is a consultant for CBI, NIA, and State Consumer Forum. He started as medical superintendent of Father Muller Medical College Hospital from 2013, and he started his career in 1988, and is the first person to start the clinical forensic medicine unit in the work in Dakshina Kannada, and is a senior faculty of forensic medicine. So, being a medical superintendent, sir also heads various committees under NABH in our hospital. So, as an NABH council member and mass disaster committee, and the organizers have selected the right person to address the present topic, that is a handling of medical legal cases in day-to-day practice. So, I welcome Dr. Uday Kumar, sir. So, over to you, sir.
Since my talk was supposed to be between 9 and 9:45, lot of adrenaline has gone down. So with time, but still, okay, I'll try to do some justice to my topic. Chairman, sir, and with your permission, I'll straight away go into the subject. I have been given 45 minutes, probably about 30 minutes I'll talk, and 15 minutes for the discussion. It's a good topic for discussion. I know a lot of questions will be coming. When you started questioning the ACP, I thought all my questions will be finished here only, right? Those are the questions actually pertaining to this topic. Anyway, probably the people have given, organizing committee has given this topic because of my long relationship with clinical forensic medicine. I started in the year 1988 as a postgraduate. We never had, in Manipal, KMC, we never had a money postmortem, so we were asked to take up the casualty duty. So there we started the medical legal work. So then, of course, it took us a long time, it took me a long time in this field. I was, as you said, I started my clinical forensic medicine practice in Mangalore. I used to see around 200 patients per month, and used to make some money also out of it. Those it is just 150 rupees per case. So in that phase, I think I saw around 20,000 cases of medical legal cases. Right then, of course, I was into crime scene investigation. So I was fascinated, and I did that journey. And later, right now, the third innings is my administration as forensic medicine. I mean, as a medical superintendent. But still, forensic medicine is connected to MS. Right? Just now, I got a call. There was an injury to the eye. I think you must have seen yesterday. Somebody hit him on the eye. He has lost his vision. This patient has gone straight to the OPD. Okay? And today he has come and fighting in the casualties. He doesn't want to do MLC. Right? Already police have been intimated. Right? They don't want to do this casualty procedure. What to do? Right? So this is how my role goes on. As already explained, I am the proud professor of forensic medicine. And Kishore said, because of me, not Kishore, Shyam Kishore said, because of me he has taken forensic medicine. I don't know, to flatter me or he is cursing me, I don't know, for taking up. Anyway, right? Now, medical legal case, right, MLC, it's a very common terminology we use. Here the problem is in casualty most of the time, either as a live patient or dead patient, right? What to do? First of all, whether to do it in MLC or not, that is the question, you know, everybody faces. Do it in MLC or not? Because the moment you do an MLC, you have a lot of problems up to postmortem. Some people don't want postmortem. So conflict is there, but usually in a casualty there will be a CMO who is a senior man with lot of experience, prudence, knowledge, wisdom. With that he will say, but do the MLC or not, yes or no, right? Generally youngsters usually ask the CMO. But in my case what happens, there are no proper CMO, it is usually forensic medicine people in assault cases, or most of the cases it comes to me to say whether it's do an MLC or not, right? Though it looks simple. The theory, like every year we teach 2 batches, what is an MLC, what is the definition of MLC, but actually understanding is little difficult. What is a MLC, definition wise? A medical case of legal nature, legal implication, having legal implication, legal consequence. This is what we teach every student, isn't it? A medical legal case is one which has these 3 components, right? What does it mean? Likelihood of this medical case landing up in the court of law tomorrow. Then next question is, I am not an astrologer, I am not a saint, how do I know whether this is going to land up in the court of law tomorrow? Yes? How do you say? Whether it's, see, ordinary malaria case is a medical case, pure medical case. Can it not stand in the court of law tomorrow? Right? If a patient dies, it becomes a criminal negligence or civil negligence or consumer something, right? Forget about that. We admitted a patient of malaria, right? Mr. Ramesh, admitted for malaria, triple positive, treated, 5th day discharged. After 11 months, we get a summons saying that he has committed murder in neighboring state. He has sent his brother here for admission, right, as Ramesh, and criminal record says he is admitted with malaria, treated, right? But what he has done a crime somewhere, next neighboring district, and he has killed a person. He is facing trial of 302. So unfortunately I had to go and say, convince the court that, what's this? Is it okay? We have not done MLC, malaria case, and he is involved in a case. Impersonation, right? So finally what happened, I had to go and convince the court that this is a case of impersonation, and judge was very nice. In fact, he asked me 2 questions. Can you identify this patient? I said, no, because I'm seeing him after 11 months. How can I identify this patient? Okay. Then he asked me straight away, so, okay, in this particular case, can he send somebody as malaria patient, get admitted there and get treated and go? This is very much possible, isn't it? You don't take any identity of the patient. Those days we never used to take. Now I think, Aadhaar card, ABBA cards, so many things are coming up. But those days, for an ordinary medical case, what identity you take? He will come and register himself as so and get treated and go, right? So how do you identify? I said, it's impossible, sir. It's not a medical legal case. It's a medical case. We don't take an identity. So thank you, doctor. You can go, right? So any case can land up in the court of law. For that matter, can you do every case as an MLC in that case? Best thing is, make every case MLC. Is it practical? Again, it's not practical. ದುಡ್ಡು ಒಳ್ಳೆ ಆಗ್ತದೆ ಹೌದು ಫಾರ್ ಕನ್ಸಲ್ಟೆಂಟ್ ಲೈಕ್ ಮಹಾಬಲೇಶ್ and Ullas, right, every case now what is the rate? 500, 1000 case, right? Anyway, but management will not allow it, right? And it is not correct on our part to do every case as MLC. Now only thing is we have to be reasonable, right? We have to be reasonable. What is reasonable? With reasons, we should be able to convince the opposite party, whether it's a court or anybody, right? So your question is, by not doing an MLC, will it become a concealment of evidence, right? Don't worry, I'm telling you, as long as you don't have intentions, motive, right? The opposite party, police have to prove that you had a motive, that's why you have not made MLC. Right? Otherwise, it will not become a concealment of evidence. With reasons, you should be able to explain the opposite party. Now, a few words about when do you say we have made a case MLC? When do you say? And the conflict is that many of you say the moment you inform the police, it becomes an MLC. Am I right? You are not informed, no MLC. Correct? No. My opinion is, anyway, my talk is subjected to correction, right? Anytime you can correct me. I am also here to learn. What I know is handful, what I don't know is oceanful, right? It is subject to correction. We'll correct. If I am wrong, please correct me. Chairman sir, co-chairman sir, and also my August gathering. Now, the moment you write the information in the register, it becomes an MLC. Okay? Need not inform the police. The moment you enter in the register, it becomes an MLC. Now, what is the so special about this register? There are 2 registers which are required in every healthcare organization. Number 1 is medical legal register or accident register. The second one is postmortem register, which forensic medicine you maintain in your forensic medicine. These 2 registers are the legal documents of the hospital. You may ask me, what about we have case sheets, case papers? They are all medical records. It is admissible in the court of law, but the credibility is low. Whereas registers, not only admissible, the credibility is very, very high. Why? Because it has got these components. Normally it's a bound long book, isn't it? Bound, because it should not be destroyed. Number 2, it is serially numbered. On the right hand side, you can see in red ink, all numbers are there, right? Printed numbers, preferably pre-printed. Why I say preferably? Because an organization like this has to have a printed long book, whereas Even general practitioners are expected to keep a register. There, I think it is too much to expect from them from a pre-printed book. They can maintain an ordinary book, right? Sequentially entered with the date and time. Sequentially entered with date and time. This is the most important component of the medical legal register. You cannot write today's one yesterday, tomorrow's today, like that. It has to be entered. Whenever you come to know about the case, you make an entry that is sequentially entered. Untampered book. Untampered means you should not put whitener in the medical legal register. Suppose accident has taken place in Bengaluru, then it becomes Mangaluru. You don't put a whitener and write Mangaluru. It is a tampering. If you want to change anything, just strike it with one line so that you should be able to read what has written in the earlier. Then on the top you write what you want to change, ideally, right? Then don't pull out a paper and fix a paper, right? Which you do. Oh, this is yesterday's case. Today I am entering it. So how to put it back? Because I have told it sequentially entered, right? There is no chance of entering. So write it in a paper and stick it there, or removing a paper. This becomes tampering. There should not be any tampering. The moment it is tampered, it loses its credibility. And in the custody of CMO. I think this is medical legal register. It has, ideally it should be like this. Ideally it should be entered like this. The moment you come to know about a case, and if you think you want to make it an MLC, you enter in the register, it becomes a medical legal, MLC case. Okay, what about what to write in the medical legal register? I think somebody was asking, madam, patient says something, we are writing, then they want change, what to do? We'll come into that. Brought by. What you write normally? Somebody has to bring a case, right? Brought by Ramesh. That's the end of it. Tomorrow, he is the important piece of evidence actually, witness in this particular case, whatever this assault case or RTA case or whatever it is. Now, if you write just Ramesh, where do you find this Ramesh tomorrow? So ideally, you write friend Ramesh or relative. Relative means again brother-in-law or whatever it is. You should be able to identify the person at tomorrow. So write little more about the person who has brought him. History-wise, the problem is what to write. As per law, the first information report given by the patient or patient is believed in the court of law, admissible in the court of law, and with high credibility, because law expects things, presumes that whatever you hear for the first time from the patient is relayed. Okay? Believe it. But whatever comes later, I'll give an example. A person was, a lady, it's a dowry death case. She poured kerosene on her head and burnt herself. 100% burns. Came to the hospital. When I saw her, she was in a state of, she was conscious, conscious, and she was clear, and she said, my husband was torturing me, all those things. Then I said, I am going to commit suicide. He always, when I say commit suicide, you commit suicide. Then he said, how to commit suicide? Hang yourself or put kerosene and burn yourself. Like, he was telling all these things. One day I thought, let me teach him a lesson, and poured kerosene in front of him. I said, why only kerosene you poured, you light it? Then I took a matchstick and I stood like that. I said, why you were waiting? He always thinking that, he was thinking that she was threatening. Right? At that point of time, finally she lit her this thing and burnt herself. 90% died. She came to the hospital. This is the history given by her. And also she said, husband tried to prevent the burns by putting hand. He has burnt both the hands. That's also there. Right? And in the history, I wrote exactly like this. Self-immolation, right? Blah, blah, blah. And after that, the Tahsildar came for dying declaration. There, again, I said, I certified compos mentis, that history taken, right? And in the history, she says, and the Tahsildar writes that it was a case of 302, where husband poured the kerosene and lit. You got the first one, what information I have given is the actual one. The second one is the afterthought, because the father and mother of the the victim went and convinced her to that extent that you should give a history like this, and she, okay. Later in the court, Mangalore principal session, I was in the trial. I was called, and of course the opposite lawyer was talking all rubbish. See, he doesn't know that I have signed for compos mentis. He says I am the witness. Whatever is written there, I am the witness for that. I am not a witness. My job is to only say whether she was in a compos mind to give statement. That's all, which I have given at the beginning. At the end again I have given, because she was in a state of mind to give. But whatever she has spoken was false. But I am not responsible for that, right? But I have documented clearly in the accident register what has happened. In the court of law, opposite lawyer also never noticed that what is the history given in the wound certificate and accident register, right? In fact, the judge asked me, what was the history given to you, doctor? Then I said, madam, you please see the my own certificate is written. It was totally different. Then she took the whole this thing into task. Then how did you put 302? The police people have signed every page of us. Police people have forged the signature of the victim in every page. Patient's hand was like this, with 100% burns. Correct? How can she sign? That's the question asked to me. Whether the patient was in a state of mind, in a physical status to sign. I said no, her hands were like this. Then who signed it? I don't know, that you have to find out. Actually, you got my point. To change from this to 302, they have put signatures also, right? Though I was called as a prosecution witness, in fact I became a defense witness in this case, because my job is to say the truth, and it was believed because the history says. That is the importance of the history. But practically speaking, if you go on writing the history, what patient party has given, that is the person brought by, you will be in trouble, right? History is written, fall from bike, fall from height. Everybody falls from height only. You cannot fall other way, isn't it? Correct? Fall from bike. Whether the bike is hit by a vehicle, whether a skid and fall, everything is a fall from fall from bike. Now what do you want to do? I am telling you the practical aspect. What to do? If you write it as history of RTA, a pillionaire was hit by a bike or a car, right? This is the correct way of writing it. Now if you write it, tomorrow the case will change. Madam was telling something, your ACP, right? The same police will come and ask me, same traffic people, sir, this is not this, sir, this is that. You have written like this, you correct and give. Isn't it? This is the usual thing what you get. Right? You know what is the theory? Now what is the practical thing now? You have written, what to do? Tell me. Every day in my office somebody will come with the accident register. Sir, it is written like this. The police fellow will come and request for change. Right? See, finally you have to use your prudence, knowledge, experience to write. What to write? I would say, now you ask me what to write. Write history of RTA. Leave that line blank. By next day somebody will come and ask you, sir, this is not at Mudipu, it is at Padipu. This is not at 3 o'clock. So who will record the time at the time of accident? Correct? So all these timings, place, everything will change. Keep that area blank. There is no hurry, because then you can, the correct information will come by somebody else. Most of the time patient will not be in a position to talk, isn't it? The bystander will, who is going to pick him out, will bring him to the hospital. He will not know what exactly is the incident. The ACP said they will see the CC camera, then they will come to know what has happened. Okay, then the constable will come and ask me, sir, this we saw in the camera, this is the incidence. Then what are you going to write? Initially you have written something, then you have to cut whole thing and write something else. Right? We are not the eyewitness, right? So first, if it is RTA, write RTA and keep the whole line blank. Right? I am telling you how to manipulate. It's a fact, it's a fact. But No, what I am saying, people may think, how can you do it now, keep it blank and tomorrow come and write? But you want to do justice, isn't it? Finally you are doing in the interest of the public, interest of the patient. Okay? So history-wise, lot of things will happen. Lot of times you may have to change the history. So ideally, no, you correct me if I am wrong, or if you have any better way of handling it, you tell me. Let all learn. Correct. Correct. Exactly I am telling. See, one police case, police encounter, a notorious rowdy was caught. Police brought him to the hospital, after shooting on the knees. Okay. My junior staff from my department, she was on duty. Assault cases are seen by the forensic experts. So there's a junior staff, just then she had joined. She wrote, there is a criminal, he knows what to speak also. Afterthought has come in the before only for him, right? So he says, I was caught hold by the 2 policemen. He names also he knows where. Then I was blindfolded, I was tied, then I was taken to a forest where I was made to lie down, and they shot me on this thing. And my staff has written clearly like that, or bat him. Right? Next day, commissioner himself landed in my office. Doctor, what sort of a opinion you are giving? What happened? Then showed me. I never knew. Then I requested Nagesh, Harish, everyone, literally, right? And what to do? Now she has written everything in the accident register. How to change the accident register, which is impossible. I only told you cannot remove, cannot add. Now what to do about this? You can't put whitener. Fortunately for my fortune, it was on the 3rd page of the new book. You got my point? So I told, change the book. Then we changed it and I asked Mike. So I am telling you some brutal facts. You can say, what? I have to somehow manage, right? I cannot go against it. Some of you may not agree with me what I did, but I did this way. I am not saying you should not write anything. Write it as assault, gunshot injury by police. Finish off. Why all this tying, blindfolding and all, as if I am the witness? And can this, see, first information should be believed, believable, isn't it? He is a bloody criminal. Is he believable personality? Right? So don't believe, don't write. Be careful, be safe. Now comes sometimes unknown patient, what to do? See, it's a very common thing, how to register, right? You write it as unknown. If it is one patient, if there are many patients in disasters, U1, U2, U3, U4, U5, U6 with a different numbers, then when you come to know about this thing, you can do it. This is MLC at OPD, I just told you. Many cases go directly to OPD. Just now, today, what happened? He has gone to OPD. Doctor has not told him, the clinician, to go to casualty and get yourself registered in the MLC, for MLC. Right? He has come yesterday, he has gone back, today he has come. Right? Somehow we came to know about it because I think police came for police intimation. This is very interesting. He has already, this case has been registered in the police station already. FIR has been done. But in spite of that, police will come and ask you for intimation. Sir, intimation yak kalasilla. Why you are not sent intimation? You know the case, why I shouldn't? But they want it for record purpose, they need it, we have to. Even if it is late, you send a late intimation, no problem. So this is another problem which you, now what to do? See, other day what happened, a patient came with shattered right hand. Yes, right hand. And he gave a history of, he was crackers, he was throwing a cracker and it got busted in the hand and injured. So my hand and microsurgeon treated it, and 4th day he came and asked me, sir, should we make it an MLC? Should we, right? Because there are multiple injury. Trauma usually will resent it, but somehow it has missed. Then I said, better, because how do you know this? It's a blast injury, right? Blast may be cracker, cracker also blast injury, bomb also blast injury. So better to register, but it's already 4 days, sir. So what? I said it should be chronologically entered. I did not say on the day of admission you have to enter. You can register at the later date also, no problem. Whenever you come to know about the case, you make an entry. That's all, you are safe. What happened, believe it or not, after a few days, I think my clinician is here only. After a few days, the police came with a warrant for this fellow, whether this person has admitted in a hospital. They found out and said, yes, what happened? Yes. Sir, he has one bomb he has thrown at somebody and damaged something. Second bomb blasted in his hand. Right, fortunately we have made an entry after 4 days, but still, otherwise we would have had little problem, not that lot of problem, because we have no connection, no intention of saving this fellow, right? We do not know who is he. You know, if they can establish the identity and our relationship, my friend or my, so many things, right? They can put me under concealment of evidence. In this case, nothing has happened. So what I mean to say is, entering a register can be done at whatever the date, even after 10 days also, no problem, right? Don't try to put it, go back and put it 5 days before. Write it on that day. Oh my God. Late entry, late intimation. That's what I said. POXO cases. I must have seen more than 100 cases in last 12 years, 12, 13 years. Right? 2 ways they appear. One is injury, other one is pregnancy. Right? All those, I have seen 4 years child being, sexually assaulted with 3rd degree perineal tear up to about 13 years, right? At least about 10-15 cases, right? Then of course, after 13 years I have seen, as they come with a history of pain abdomen, surgeon will send it to radiology, there they do the ultrasound and say sac, pregnancy is detected. Straight away they send the patient to my room, right, with an attendant and the victim and the mother, mostly, right? What to do now? It's a major problem. Okay, first we'll say child rape, POXO. All of you know, if you don't inform the police, you will be 6 months imprisonment. Allah? Son, right? Okay. So, initial days, I used to do that. Promptly I used to intimate. One case I'll tell you what happened. I intimated the local police. It went to Kerala, Kasaragod district case from Kasaragod, 4-year child. So no action was taken, right? Mother was there, child was in the hospital. Then I called up the SP. I knew the SP. I called up SP and said, this case has come, nothing is happening. Then he told me, doctor, this is the 9th child, okay, of this family. He is the sole breadwinner of the family, father. Now, we have called the mother to the police station. Mother says, no problem, sir, you make a case and send him behind bars, right? I will commit suicide, the mother says, and these 9 children, you only. This exactly he said. And SP says the same thing, sir, you inform, you do all the legal procedures, and she will commit suicide, and you look after the children. He's asking me. I'm telling you frankly. Then I started thinking in that line, oh, social responsibility. She should not die. They should not commit suicide. They should not fall on the road. What to do? What to do? Nothing will happen, what I mean to say. If you intimate to the police, most of the time these small children of 4, 5, 6 years, it's usually the parents, uncles, same family members are the accused, right? Perpetrator of the crime. Nothing will happen. If you get a police information, only they will be harassed either financially, and this thing, nothing will happen. I'm telling you frankly. Okay, next is pregnancy. Right, very, very disturbing area. Right, I know you have a lot of questions to ask about this, but I'm telling you the facts because personally I have done. No, I'll come into that. I'll come into that. You can't do that. You have to intimate, right? You have to intimate. I'm not saying you should not intimate. There's a CWC, Child Welfare Department, all those things are there. But what is going to happen, I'm telling you, right? Yeah, not always, not always. See, I'm talking in general. See, when I speak here, it is not every case. It is in generally what happens, right? In my 10-15 cases of child, this thing, hardly 1 or 2 cases have, people have gone behind bars, right? Now, I'll finish off first, then we'll discuss. Pregnancy, about 13 cases. I have seen so many cases, not just maybe 80, 90 cases of pregnancy. Again, they will come, what to do? It's a boxer case, right? Right? Again, the culprits are usually family members, right? If it is a rape case, somebody, if the girl says, she was raped by somebody, yes, it's a case of boxer. These are all finally, yes, this is my would-be husband. Next year we want to marry. She is 17 years. Usually they're 17, 16 years, the boyfriend. Okay, now what are you going to do? And I'll tell you, when I counsel, they say, it is not one case, maybe 50, 60, 70 cases. Sir, it is my uncle. I'm going to marry him. Okay, fine. Now what to do? She is 17 only. Want to intimate the police? He will go behind bars. Right? She can't marry also, she is less than 18. Now what are you going to do? And she says, sir, if you intimate the police, I am going to commit suicide. First thing. And the mother says, sir, if she commits suicide, I will also commit suicide. And uncle will go behind bars. That is the end of it. What to do? Sir, that's why I am saying, let's not discuss that part, we will come to that later. I will come to that. Police intimation. See, I am opening a Pandora's box. I am telling you, I am opening a Pandora's box for discussion only. I am not saying, I am telling you what can be done. I'm just giving you a scenario. See, these are the things, how best you have to. If you have answer, you please give me. It's a good thing he said. It's a murder case. Will you keep quiet? Okay, next. Police intimation. Intimation book will be there with the CMO, DMO. Nil MNC. A word about nil MLC. It's the usual thing is used now. What is nil MLC? Police intimation not sent. You take the signature of the party. Okay. So there is nothing like nil MLC. The moment you enter in the register, it is MLC. Whether you intimate or not, it is your job, right? Then you call it as nil MLC. Now, is there any, do you have discretion to intimate or not to intimate, right? So if you intimate for every case, for example, the police themselves once asked, sir, for every case you are intimating, right? For unnecessary case you are intimating. Patient has taken, your student has taken 2 tablets to threaten the mother because she has not sent the money. You have made it MLC and you are intimating, right? It's a common thing, right? Yes or no? What do you do? I think see the section 39 CRPC, right, where they say, now it's of course, CRPC has changed the terminology. Earlier 39 CRPC, you see what it says. These are the IPCs where you have to intimate, correct? It clearly says section, which are the section right from 299 to 308. Here I think all assault cases, the 375, all cases they say, these are the cases, it is the duty of the general public, not only doctor, and general public to intimate, where to intimate. Now, but one exception is there, 309, which was attempted suicide, which was in and out of IPC, right? Now I think finally now it's there, right? This is an exception in 39 CRPC, so it is your discretion to intimate or not to intimate. EDR, I think either Madam has told already, for accident victims. Only thing is, you remember last point, immediate intimation is required in these 3 cases. Otherwise you can wait. How early you have to intimate? Number 1, hit assault case, because the assailant can run away, so immediately intimate. Then comes hit and run cases. Here also you have to, because the vehicle will run off. And finally, if you want to take a dying declaration, you have to intimate immediately. Otherwise, you can wait for some time. Nobody will question. In our hospital, we send intimation, one in the morning, once in the evening, right? 12th hourly. Otherwise, 20 cases, almost 20, 25 cases we get. How many? 25 times you have to run and police fellow says, that fellow also shouts at us. So then finally asked the IO and said, How can I send it? Sir, once in the morning, right, night cases, and in the evening, all the day cases, right? So, but if you get these cases, intimate directly. Now, of course, you have email system also. Now, lastly, death cases. How much time I have? Another 5 minutes. Another area is death cases, right? Broad dead cases and home death. So, dead on arrival, see, home death comes as a broad dead, and of course, dead on arrival show some signs of life at the time of, but still you cannot give you have not diagnosed the case. Why this is home death is where you don't have a diagnosis, right? Clear diagnosis. Next comes hospital deaths, no problem, you have a diagnosis. Now, no signs of, now is this an MLC? You want to make an MLC. All broad dead cases are MLC, isn't it? And you have to intimate. Another conflicting area where you, if you are a hospital CMO or thing, you will have this problem, right? I think last week a snake bite came to the hospital, referred from one hospital, and we have a habit, we don't have beds, ICU beds, so my team goes to the ambulance and check, try to assess, triage, and say if it is dead, okay, broad dead, they'll say no chance already. If you want to take inside and do ECG and will confirm death. Okay, but many people, they know now, broad dead means it becomes an MLC and postmortem. Many of them, why postmortem, right? So they will take away the body. The same thing happened, this snake bite case, he came, my doctor went and saw the case and said, sir, yenilla, death agide, it's already dead. So he took the ambulance and went off. Now I get this thing that why you are not informed the police, why you are not made it MLC, all these things have come, notice, right, what to do, right? So I have answered that, this has happened, what has happened. See, I don't know what is the name of the patient also, right? Patient, the moment my doctor has seen and declared dead, not declared dead, suggested that he is dead, they said they are going to the same hospital where you have initially treated and went off and cremated. Now, what to do? If the patient you have taken, you have registered, then the question of registry. If you are not registered and patient party doesn't want all this, right? I usually ask them to go. Again, it's a conflicting area. I know it's not right, but if you take them and say make MLC, you will get beaten up sometimes, right? My grandfather, who is 98 years, right? No response. I have taken to the hospital, and these people want to make MLC and postmortem. Correct? Our system goes like that, right? The moment you inform, it is police will come and order for an autopsy. And why should my grandfather, who is 98, should undergo this? Correct? Right, sir? So what to do? Now, what is the legal this thing? Legally, yes. Nobody wants to take the responsibility. So I will make it MLC and, right? So old man, that's what I said. Suppose a young boy, better to an MLC because you don't know, right? And convince the patient party, see this is a problem. Tomorrow there's somebody say something. Person staying alone, right? Many times it has happened. Person stays alone in room or hostel, something. Better to do. Suspected poisoning, better to do. Snake bite, I told you, better to do. They get some money also. Victim of disasters, right? Mass disasters, victim of disaster of any kind, even bulgur injury, snake bite, anything, right? Better to an MLC, right? So, PM examination, required or not? Again a problem. Required. Can you avoid postmortem after declaring as, MLC and intimating the police? Yes, yes, very good answer, yes. But in practically speaking, no police officer, actually it is the discretion, 174 CRPC, what it says? It is the discretion of the IO to submit the body for postmortem examination or not, right? How many police officers do this job? The moment you give, they give the order for post-mortem, yes or no? But there are police officers, right now this police officer is in, he was in Ullal, here only. At least 10 bodies he has released by doing a inquest. He has called me, sir, in this case, do you require a post-mortem? I said, it is your job. If you ask me to do a post-mortem, I will do, right? Otherwise, if you give a clearance, we will release the body. Then within 10 minutes, he goes to the scene of crime, right? And makes an inquest and says, I don't have any suspicion about this death, and please release, and use a letter. At least 10 cases I have done in Father Muller's, and I will tell you the police officer's name also. He was in Ullal, Pramod. One Mr. Pramod, right now he is, I think, in Surathkal, right? Ask this person, he will release the body, provided he goes, he will do the investigation. So it is possible, it is the discretion of the IO, but most of us don't have guts to do this, because most of us are corrupt. Many of us, sorry, not most of us, many of us. So when you are corrupt, you lose credibility, right? You don't have guts. But if you are a non-corrupt person, you will have this guts and you will face it. Death certificate. Can you give a death certificate? Can you give death certificate? Hospital death. Patient is in the hospital for so long, right? Am I right? We don't know what is the case. He has consumed paraquat. We have done stomach wash, everything, dies, right? Actually, it's not required. Police officer can say, if you give the death certificate, I can, what is the necessity of this? Prove. We have taken the stomach wash says, has got so much of paraquat, right? But no police officer will ask you to this thing, postmortem is done, right? We are in fact giving that certificate to the registrars of birth and death, but we are not giving, we are waiting for the postmortem report. All unnecessary, but we are doing it. Lastly, postmortem certificate and wound certificates, whom to give? See, wound certificate we prepare in 3 copies. First copy for the police, second copy for the patient party, third party office copy, right? Yes or no? Yes. So I was doing this during my heydays. Once I went to Thrissur court, the judge asked me, look, he was looking at my wound certificate like this, finally asked, doctor, did you issue this wound certificate to a patient party? Yes, Your Honor. Why did you issue? I said, this is the protocol, policy we follow. We prepare in 3, 1 for the police, second. No, you should not issue. Then I said, Your Honor. Then he said, see, the moment you declare it as an MLC, the patient is a property of the state, right? You can only issue documents to the IO, nobody else, or court, right? Hereafter don't issue, right? But how to get the, he has to go to the police station, pay 2 rupees, treasury charges, and the treasury will put the seal there with the 2 rupees, and that certificate only police can issue. We should not issue. Rule says, but we are practicing this. I don't know whether it's right or wrong. It is for you, and I think Harish Gowda and team, they don't issue. They really follow strictly. Even if I request also, they will not give. Now the problem is, even postmortem certificate also same thing, but now the problem is accident cases. Karnataka, see, I think police, I don't think there is any. There is. I think Kerala court only asked me this. Anyway, next comes, now the problem is, wound certificates and PM certificates are required for the patient party for the claims. See, now earlier accident claims used to be in civil courts, then it becomes MUCT, right? Now, insurance companies are clearing compensation outside the court, outside the tribunal, right? KSRTC for that matter, KSRTC, our Karnataka transport, people come to the hospital and the patient is admitted, right? they will come and ask for settle the case. That's end, right? So you may have to give in such situations. I think I am well within time.
Sure. Thank you, sir. Thank you for your
you so much.
Valuable suggestions. Because we are actually agree with you, sir, because we are also practicing clinical forensic medicine. This problem will be there with us. And we are from this place only. Yeah. Yeah, sure. Sir,
sir? No, I fully agree with both. No, sir, I fully agree with you. He has already explained. He has also told me. See, I am not saying not to intimate. Wait. No, I am saying not to intimate. I said what happens when you intimate.
And don't be caught by the doctor. And he had to do something which is required by the law.
That is true,
So
sir.
we have to do that.
Now-
And if you take decisions by sitting in the casualty itself, that may not be good.
No, that's right.
Law,
No, I will clarify again. I said I will going to discuss about it.
you must understand that law is not a science. Law depends on too many factors to decide a fact. So one of the component is us. So we have to report everything to the court.
sure. You know,
Actually, what sir spoke is it is a open up matter about
That's what I said.
sir.
Actually, in Foxer cases, it is mandatory reporting, sir. And that is what we are following even in Karnataka also. Not only Kerala, everybody throughout the country, you have to follow that.
Okay.
That is mandatory.
Sure.
But the thing is, when you come to the social responsibility and the legal responsibility, always legal responsibility has the upper hand. We have to go according to the law, not according to the social responsibility. Because law has clearly told that POXO cases less than 18 years, it's a mandatory reporting. So that is what even Karnataka also are following, not only in Kerala. Everybody has to follow that. This is what
Sir,
I
agree with you. Sir, agree with you. Having said that, certain problem happens sometimes. This has happened for me also. We informed, but where is madam? Where was madam? Yeah. Okay, thank you, sir. Thank you very much for your presentation, sir. Uday sir is a person, he helped us physically, mentally and financially for this conference. Thank you very much, sir. Physically and mentally. He attended so many meetings with us, physically. Thank you very much.
Thank you very much, sir. I request the chairpersons to hand over a memento and a certificate to felicitate Dr. Uday Kumar. I request Dr. Shyam Kishore sir to felicitate Dr. Kishore Kumar sir and Dr. Harish Gowda with a memento and a certificate. I now invite Dr. Umesh Babu, who is the professor and head of the Department of Forensic Medicine and Toxicology, Kodagu Institute of Medical Sciences, Madikeri, and Dr. Pratik Rastogi, who is a forensic medicine professor from KMC Mangalore, to join as the chairpersons for the upcoming session by Dr. Mahabalesh Shetty, who is the Director of Student Affairs from Nittei University, who is also a professor of Forensic Medicine and Toxicology from KSEC Medical Academy. We welcome you, sir.
It's my pleasure to introduce Dr. Mahabalesh Shetty, sir, to you all. Sir is currently Professor of Forensic Medicine and Toxicology and Director Student Affairs at Shema, Mangalore. Sir has completed his MBBS from JNMC Belgaum and MD from KMC Manipal. He was the ex-president of Kamals and ex-president of South India Medico Legal Association, with numerous published papers and numerous guest lectures to his credits in international, national and regional forums. He is a recipient of Distinguished Teacher Award from Nittei, felicitation recipient from Manipal University and District Administration Karnataka Media House for contribution towards drug-free campus in DK district. Sir is an honorary medico-legal consultant for Government of Karnataka, forensic expert and medico-legal consultant to COD Karnataka State. We welcome you, sir.
Good afternoon. Respected chairperson, co-chairperson, my teacher, Uday sir, and my dear friends. The topic is usually, I think it's overlapping topic, evidence deposition in medical legal issues. Because this topic is not for people who already visited court. This is for those people, for UGs, postgraduates who have never been to court, and to clinicians who are planning or who may be called to the court in future. My topic will be this way. Because of time constraint, I will just go. What constitutes medical legal case? Sir has told in a different way, I will put it in a different way. A case which requires medical treatment as well as information to law enforcement authority. Any case can land in the court of law is considered as medical legal case in simple language, layman's language. So we are not the one to decide what is medical legal case. It is well defined very clearly by law. Or later law can consider that this case can be a medical legal case and call you up to the court of law. Am I clear? A case which requires medical treatment ends up in court of law is a medical legal case. So as sir told, malaria case can land up in the court of law, not because it is a medical legal case in the bracket, but due to some other reason, it can land up there. And you as a treating physician may be summoned there. So I did not explain RTA, bomb blast, bull gore, snake bite, so many fall, so many things are there. It is never ending story. I put it in a very simple language, hope you understand. So deposition process and legal framework. So we are guided by certain laws, BSA, like Indian Evidence Act previously. Now it is BSA, BNSS. So many things are well defined there. So in certain things in 184, sexual assault case, rape, accused examination, victim examination, or in case of medical negligence, or in case of ethics, we may be called, people may drag us to court of law. Not only in medical legal, it is a personal attack. Somebody tells something, defamation suit, you may be landing up in the court of law. Consumer Protection Act, because recently couple of cases I have been in Kerala as an expert for Consumer Protection Act. I'll share my views. And in personal loss, it doesn't come under medical legal case per se, but somebody can call you that to certify that this particular person is suffering from mental illness or certain things for compensation, other things. Okay. Now we are dealing only with previously Indian Evidence Act 45 was on the tip of our tongue. So we used to remember the same thing has now become 39 to 45. It deals with Indian Evidence Act of expert opinion. Who is expert and what is our opinion? So very simple, a case involves technical matters like forensic science, forensic pathology, medical knowledge, whatever comes under expert, because the court per se is illiterate, medically illiterate. They may be a PhD or whatever, they are medically illiterate, and they summon us to make them understand what is right, what is wrong. So we come under that bracket. So just to highlight, what does it say? Technical, fingerprinting, all those things come under that. The court assesses the qualification and credibility of the expert. So we go to the court thinking that we are the doctors and I am not come to the procedure per se. We are supposed to be well dressed and well spoken. We should be standing upright, and our general demeanor should be very standing and not like that we already lost something. So expert opinions, even if detailed, are not treated as conclusively unless the expert's reasoning and conclusions stand up to a scrutiny under cross-examination. The more rigorous the cross-examination and more convincingly the expert responds, the more weight the opinion gets. Section 59 BSA says very clearly, we have got the right to open any book or any document which you want to pursue. No other witness is got. Please remember, that is an advantage for us, because our case will come after 10 years, 14 years. Even today I have got two cases about two warrants from Kerala. One is from Talsheri and one is from Kanjangat. I have not gone for that warrant. Okay. But the reason is very clear. The judges know that we are busy with certain things. But Section 159, please remember, you have got doubt of something, you can just open and see. In Karnataka, we have been privileged in the Sessions Court to open even a laptop. Recent case, and then that particular case, I will discuss that also. So, where do we stand as an expert? Supreme Court of India held that expert opinion is just an advisory and intended to corroborate other evidence, not to substitute for it. So we, as a medical legal expert or medical legal consultant or forensic expert, our evidence is not conclusive. It is just an advisory to the court of law. Who is the expert? Judge is the expert. Conviction or final decision should not rely solely on the expert opinion without corroboration. So if I say I have got 100 convictions as a forensic expert or 400 convictions as a medical legal consultant, I can't take the credit because mine is just an advisory. Court is the expert. The Supreme Court has emphasized that conviction cannot rely solely on post-mortem report. Definitely my role as a medical expert can play other way also. If an eyewitness says this is by stab, I say this is by firearm, the case will definitely fall. Benefit of doubt is always given to the accused. The overall evidentiary value, not the mere presence or absence of medical document, decides the outcome of criminal trial. What does it mean is, even with the without the medical document, even without the post-mortem certificate, convictions have happened in India. Even without the wound certificate, courts have come to conclusion and they have decided that this is a case. So please remember, where do you stand? Nowhere. If people think we are the boss because of my report, for those people, this is for the PGs, especially my talk is about for PGs. Please remember, we are not the supreme. When you go to the court of law, it is the judge. In recent case, Solanki versus State of Gujarat, the Supreme Court noted that medical evidence is generally corroborative but can be used to discredit eyewitness if it proves injuries could not have been caused as claimed. If there is any diversion from eyewitness or the medical evidence, the benefit of doubt is given to the accused. So whenever there is an eyewitness, as far as my limited knowledge goes and my limited presence in the court, where I have deposed in more than 2,000 criminal cases, I think it's a big number, 2,000 criminal cases of 9 districts, of 2 districts of Kerala and 7 districts of my state. where I have seen different kind of judges. My experience is, I had a very good experience in Kerala. Courts are extremely good. Kerala police are not that good as Karnataka police. Karnataka police is good, judiciary is not that great. This is what my experience, because I have deposed more than 500 cases in Kasaragod and Kannur, Talsheri, in evaluating, accepting or rejecting expert opinion within the legal context. So we, after doing MD, MS, MCH and whatever cardiology, and this particular person goes to the court of law and does the defense, who has to decide? Judge has to decide. He will decide whether this is right or not. In medical negligence, he will decide. Direct evidence receives greater evidentiary value than the expert opinion. So judge is the expert of expert. So section 3 of Bharatiya BSA establishes that the basic rule of what may be admitted as evidence in court proceedings, only facts that are either directly in issue or declared relevant in the later section of the BSA are admissible as evidence. So you get someone says CW, PW, DW. What does it mean? Court witness. Court witness is especially exclusively for expert, because he is giving an opinion to the court. He is an advisory to the court. Okay. Prosecution witness. Most of us are called as PW. Sometimes we may change to become CW. Because after everything is over, the court may ask us, especially. And please remember, we as a doctor have got a right to be volunteering certain things. Certain times we volunteer. When we start volunteering ourselves, no other person has got that right in the court of law. The medical profession has got that right, because we are considered as independent, respected in the society, and we can volunteer. Sir, this case is going this way, so I want to volunteer something. Minute you start volunteering, the defense lawyer thinks something else, but judge will listen. If he's a good judge, he will listen. Especially in my experience in Kerala, my experience is fantastic, awesome, because judges will listen. In Karnataka, they will not listen. If I say tympanic membrane rupture is due to the slap on the ear because negative pressure is created, judge will say no, he has fallen and that stick has gone inside. Sir, it is S-shaped, it won't go. No, it has gone, you don't know. I have seen. When I was small, when playing, it was went inside. But external injuries will be there. No, you don't know, my experience. Then you have to keep quiet. This is a state of affairs in my state, okay. Doctor's testimony may serve the interest of justice irrespective of which side calls him. So we are man of science, whether prosecution calls or defense calls or court calls. As sir just told, I've been called as a prosecution witness, I may become a defense witness. Because I have got nothing to do. I have to tell the truth. That's what we are. Doctors can be a fact witness when I say these are the ABC 1, 2, 3, 4 injuries. Or expert witness when I say this is caused by this particular weapon. Then I become an expert. Opinion. My opinion. I have got the right to give opinion. Okay. How did he die? What are the age of the injury? All those things. Medical professions have a primary duty to the truth, not merely to the side that called. That is my principle is that I don't go and meet public prosecutor. I may be wrong. Okay. I am not telling my PG students that don't go, but I never go and meet. The minute I go, I will be prejudiced. I will be biased. So even in Mangalore, whenever I go, or in Kasaragod, I just go at 11:30, 11:20, tell the court PC or the bench clerk that I will be visiting at 11:20. The minute I go 11:20, 11:25, they will call me directly, come down. Whatever I have to discuss or depose, I will depose. Argument, it may go for a couple of hours or within 15 minutes. The best part is I never go and discuss with the PP. I may be wrong. The reason is I will be prejudiced. These people will put words in my mouth and ask me to utter that same thing, which I am not, and very clear about that. Be a man of science, no enemy to avenge. I believe in this particular thing. So even my back in my department, I used to put all these things. Even when I give a TV statement, I put all these things. So honestly state, I don't remember. This is very, very important. I start cooking up the cases is impossible. You need not remember anything. So I always say, I don't remember. I always say, I don't know. There is nothing hard that everything I should know. So I just like to share a few of my experience. So section 63 is a cornerstone in the admissibility of the electronic records. So of late electronic records is started. Because of this particular thing, police start sending WhatsApp messages. Yesterday also Supreme Court told very clearly, yesterday, that no more summons served is WhatsApp is valid. But all WhatsApp message I get from Talcheri, Kasaragod, Kerala, Kannur district and Kasaragod district. Maya also. So what I am supposed to do? But if I fight with those people, then they may come here, I am troubling them and all those things. So I usually go. Acknowledging their work, I go. But in reality, Supreme Court has told, don't go. That is the reason I think I am not arrested. Because so many warrant is there, they are not arresting me. Yesterday also I told, you get me and take me and go in your train and drop me back. Because I get hardly 500,000 rupees, it's not worth. So you keep it all or make a video VC. So what has happened is, even in the VC also they are creating a lot of problem. Mandatory certificate for authenticating electronic evidence. So all these things, seeing that it is very difficult, rather go and come. This is one of my PG who is working in Kolancheri. This much we are supposed to send, saying that details of electronic device used, desktop computer, made, manufacturer, Dell, service tag, which all I don't know only. How I will search? So I am not technically, not tech savvy, but they asked me, you have to send this thing. Then when I saw this particular thing, it happens to Subin George. He was my PG. So he was a good tech savvy person, and I asked him, what is this? Sir, you have to send this way, you send me, I will prepare and give. I told, no need, I will go to Talisheri and come. So documentary evidence refers to all documents written, printed, electronic or digital produced for inspection in court to prove or disprove facts at issue. In the medical legal context, document must generally be authored by a qualified practitioner, properly authenticated and maintained with integrity as per the BSA. So we go to court of law, they will ask first thing, whether there is a signature in the case sheet. So I make it a point that first thing I sign and go before going on, because you get the summons, sign. Is there a signature? Yes, my signature is there. Where is written? First page only. What else is there? Only my signature is there. You asked one question, is there any signature? That is yes. So more yes makes sense, more no makes nonsense. The court, what they want, more no's to make the case weak. So I will tell you, the service telling preamble. The preamble in the wound certificate doesn't carry much importance as per the court of law. Who brought, who, where, when, why, all this doesn't make any difference. It just adds corroborative. Why? Because we as a neutral doctor, because I got no other vested interest on the person. Assaulted by Mr. ABC, addition. Assaulted at what time? Addition. Assaulted at this place? Addition. That is none of my business. My business is only the wound certificate part. It has been told to me after 5 to 10 years of experience going to court, in a sessions court in Kasaragod, judge told very clearly to the opposition defense lawyer, it is none of his business. He writes, no, it's okay. But his wound, he has mentioned. Now coming to these are the documents which we submit. Okay. Courts generally treat medical documentation as a corroboratory, not conclusive. So these are the things. Documentation, I am not going to go. Complete record, your signature has to be there, then only we can talk about that particular case. Even if you are visiting, as a wound certificate is given by you, but in the case sheet your name is not there, your sign is not there, it becomes one no is there. So one no makes little difference. So why not just put a signature on the first consultant? Okay. So major issues is doctors are not ready to go to court of law. Here in Mangalore, what has happened is the judge thinks expert of expert. You talk about submarine, he knows. You talk about Rafale, he knows. You talk about landing on moon, judge knows. Scientist of ISRO doesn't know, but judge knows. So this is the condition situation in India. So what has happened here is, our neurosurgeons, as Dr. Ullas knows about it, they punish the neurosurgeon, make them sit for whole day. Punishment. So none of the neurosurgeons are ready to go to court. But if you don't go, they will get them to court and give punishment, sit for whole day. Orthopedician, I will never go to court. I am an orthopedician leading. Your dad is also called. If he is in heaven, he will be also summoned there. So they will call them, make them say punishment. So what has happened is, they consider doctor as just a medical doctor. Not as a cardiac surgeon, not as a gastroenterologist, nothing more. Just a MBBS, doctor, medical officer. So please remember, when you go to court of law, you are just a medical officer. Yes, in the hospital you can wear suit, boot and say, I am a gastroenterologist, I don't look at forensic. But in the court of law, we are more entertained than you as a gastroenterologist. If they act smart, I can always go to the court of law and say, I have not treated this gastroenterology case, you call him sir. Just one word. I have done many times. If anybody acts smart with this, we have got ready-made answer in the court. Sir, I have not treated, I am not a gastroenterologist, you should call gastro. What is his name? Full address, phone number also, sir. Immediate. We are the one who protect them from not going to the court of law. This is what we are doing. This is about clinical practice we are talking. Fear of legal complication, harassment, time constraint, professional commitment. Yes, clinicians should be seeing only patient, but they should be down to earth also. My student is there, very famous infection pulmonologist. You know, infection. He will think, oh, this sir is targeting me. No, he has to see patient only. Okay. Multiple adjournments. Punishment is what? They will make you sit till 1 o'clock. The defense lawyer will tell, I can't talk, sir. I have got this thing. Then he will tell, talk loudly. Nice I did, no, to this doctor. So whole day they will make him sit, send him back. So these kind of things they will do with clinicians. Technical difficulties, and we as a doctor will go to the court of law and talk all this medical jargons and saying all this. And in the court, you are not able to tell elbow joint in Kannada or wrist joint in Kannada. Knee joint, certain words they word in Kannada. When I go to Kasaragod or Talcheri, they will talk in Malayalam. In assault case, full this thing. You know, Malayalam Anslo, Allah Anslo. And that fellow start in Malayalam only. Full argument. Then I can understand, but I am not fluent. Then I will tell judge, little bit headache, sir. I can't stand today. Then I will tell you a couple of stories, my experience I will share with you. Police can summon accused suspects or witness through WhatsApp or other kind of electronic messages. That's what BSA said. But Supreme Court, 2 judge benches again yesterday told, don't accept it, so I am not accepting it. Or you can accept. But we are going as a goodwill, because we need police also. Doctors in witness box, as all of you know. See, if I don't know, as I told you, I always say honestly, I don't remember. I don't remember. I will never say I don't know. I don't remember. And there is no rule that I should remember everything. If I remember everything, then I will get Nobel, sir. So I don't remember. I have told this couple of times in the court of law. So when I was a PG student in Manipal, they used to tell me, you should prepare and go. Prepare and go. What to prepare? Whole forensic medicine, anything can be asked. So once I went to one court in Kasaragod, and before going there only, they told 10 times, High Court judge, High Court senior lawyer is coming, you have to come. PP called, police called, SA called, everybody. Don't miss. If you miss, then you will get arrested. So I went, same as 11:15. Before reaching Kasaragod only, 15 calls. Kumbled call. Manjeshwar call. Where are you? Where are you? What happened? you come that judge, lawyer has come. Okay, I went there. So when he stood up, 10 people will stand to scare, and they're carrying all books, all his juniors. Okay. He thought, I am a orthopedic surgeon. He never knew. I am a forensic. Judge knows, all other people in the court knows. Today he will get. First question he asked, doctor, what is primary impact? Yes, primary impact, answered. What is secondary impact? Answered. What is secondary injuries? Answered. What is dicing injuries? What is paraleg? That is same. Then he is going on asking 11 questions. Then I asked judge, sir, am I come here for Viva examination? He is not come to the subject yet. Then judge asked him. Judge was telling the senior law, he is a senior. Sir, what do you want to prove from him? No, I want to prove whether he knows the subject. I know, sir, but what do you want from me? Because I want to prove that you don't know anything. Now, he has answered all 11 questions. So now what do you want to prove? Now nothing, sir. And that particular case, because you were so arrogant with me, I was very firm. Whatever you asked, no. It could be due to fall, no. Why no? No, because no associated injuries in the body. There is no abrasion, no condition. So judge eventually was in my side. Who is expert? He is expert. Who has done MBBS? He has done. What you have done? LLB. What he has done? He is MBBS. He is forensic expert also. He is forensic person. Monthly. So this is what happens. When the opposite party becomes very arrogant, we also should be very arrogant. Whether I know subject or no, but I know big no. 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 That's what they ask. Hello, sir. Okay. Cases in real world and challenges what I faced. So we in medical legal as a consultant, when I go in a hospital, in Mangalore what happens is, Kasaragod and Kannur case, they come to Mangalore, succumb to injuries, body taken back to Kasaragod. If it is a murder case, it will go to Kannur Government Medical College. So in wound certificate, we will write only 7, 8, 9 injuries, maximum. Or if more, yes, all fatal injuries we will be writing. All grievous injuries we will be writing. The minute it goes to autopsy, 25 injuries will be mentioned. So I don't want to name the doctor. So doctor told, that is his mistake, he has not incorporated this. Then it was me. Everybody thought I will get my pants down. So I went and stood. Yes. Defense over, prosecution over. I volunteered to the prosecution. You asked this man, why you have mentioned only this much injury? Then I wrote and gave. He is not ready to ask. He asked, why you have mentioned only 6 injuries? So I told, my primary role is to save the patient, not to measure the injuries in the buttocks 2 into 2 centimeter, 3 into 3 millimeter, or in the toe, in the sole. So the defense lawyer started arguing. Doctor, after the patient died, while coming to Kasaragod, Periyaram, so many injuries have happened. Am I right? You are wrong. Then from where this injury came? You are not written. My role is primary. I don't carry tape and measure injuries. My aim is only to measure the major injuries, because there are already 4 doctors over him. What I can do? So I have measured only fatal injuries and I have written. Is there anything else? No, you have mentioned everything. Why did you mention only injury number 3 as sufficient in the ordinary course of nature to cause death? Because I for one believe that that is the main injury. That's why written. You can't write because this, you are not that. I told, that is what I read. And judge told, who is doctor? These questions we can be heard only in Kerala. In Karnataka, who is doctor? Lawyer is doctor. What are you? I am accused, standing there. Even after doing all these natak, we are facing. But somehow we have managed it. So one more thing. Recently, we have been to one consumer court as a defense for a orthopedics case. one doctor in same Periyara Medical College has given cause of death is due to medical negligence. I as a doctor, not a judge, I can't write medical negligence. I can say these are the findings. I may be wrong, but I don't know, in Kerala that person has written. So I went for a defense as a defense for the orthopedician, almost 1.5 hours question. So things got okay. Judgment was supposed to be yesterday. So I think doctor has been left. If doctor was fined, they would have called me. Upakara adre yaru matadudilla. Upakara andre he got help means okay. So okay, that's fine. So one more case recently, Kasaragod Golds, which you must have heard from in Kerala. That twin murder case happened in Mangalore, buried in Kasaragod. I was the one who went for exhumation. There we have recorded everything, as PG Subin was there, who was good in all this tech savvy, geotagged and all those things. I never heard of it. I thought geotag is GIO. I never knew GO those days. Okay, not now. So in the court of law, judge allowed us to use our computer and told only one thing: disprove this Dr. Mabde Shetty is not in the grave of that person. I was thinking, my God, if my parents listen, I am in the grave. I was okay. I was very serious then. Sir, I was not in the grave, sir. I was seeing the body, sir. Okay. So these kind of things, and judge accepted our thing just because we are there inside the grave and helping and seeing all those things. Video, photo, everything was there. Then accepted it. There was a procedure lapse even by the police, because out of 5 kgs, only 2.5 kgs were collected. Rest 2.5 kgs, you know where it went. 2.5 kg gold. Okay. So, but still judge considered that body from Mangalore went to Kasaragod, and Dr. Mabde Shetty is a neutral person. He has got nothing to do. And from here he went to that particular place, climbed 3 kilometers hill station, and he was inside the grave. That's what was there in the judgment. So accepted. So please friends, whenever a medical legal case comes, don't get panic. As I always say, which case lands where we don't know. Think that every patient is litigant. The minute you think that this is my brother, this is my sister, nobody is there. So please remember, every case is a litigant. It may end up in the court of law. So be prepared. So always take help of forensic people. It may be me or anybody. We are all free. We don't ask money for consultation. Okay, recommendation. Standardized medical legal reporting format, as sir was telling, I disagree with sir. Whenever it comes, sir, just open the Pandora box. Social, there is a lot of difference between ethically, morally, legally, socially, lot of difference. But as the end of the day, we are man of science, we have to follow the rule of land. There is no other option. And if so many people told in Karnataka you won't mention POSCO, we all do the same thing what we are doing in Kerala. Don't worry, we are rule of, sir just told why not this, because that fellow is committing suicide, this fellow is committing suicide. End of the day, recently just discussion, yes, that's a discussion. Recently one case was there, a girl was 18 years or 19 years, the boy is in jail, girl is delivered. That case, Uttarakhand case. What has happened? Boy is in jail, married, legally married, produced, everything is there, but somebody complained, boy is in jail. Girl is crying with a baby. What to do? Now, who has done? And recently one more case happened. 17 years old girl came to Mangalore, immediately informed, and she gave one person's name. That person was in jail for 1 year. Then DNA came. In Kerala it takes little long for DNA, almost 6-7 months. 6-7 months that person is in jail. Then that it was not that person. She named one more person. One more person went, 6-7 months he was in jail. No, not that person. Now she is remembering, who is this person? Half the people were hiding. Whoever has gone to that people, then we knew, oh, these are the people who are gone. No, these are the things we face in real life. Okay. Okay, in conclusion, it requires specialized approach and expertise, as we are not saying we are experts, but seeing day in and day out many cases, broad dead case is the biggest problem to all of us. We don't know what to do with this broad dead case, because the minute we say broad dead, go for autopsy, stones will start flying. So we always use helmet and tell broad dead, let the stones come and eat. So this is the problem we are facing. When we say broad dead and will disappear, we'll just intimate police and police will look after the matter. Current system faces significant challenges in documentation and presentation, need for collaborative approach between medical and legal professionals. So please, the court doesn't know who is doctor, who is postgraduate, who is gastroenterologist, who is forensic. Everybody is medical officer. What to do? Technology integration can improve evidence quality and management, continuous education and training for essential for stakeholders. This is about my presentation. Thank you for patient hearing. Any doubts, you can ask me.
If at all students coming with paracetamol overdose or some.
The paracetamol and all, if it is life-threatening, if you as a doctor, if you think it is a life-threatening, better to intimate. If he stays there for a couple of days in the hospital, better to intimate. Tomorrow, if something can happen, 5 paracetamol, 6 paracetamol doesn't make much difference as far as my limited knowledge goes.
But MLC has to be done.
Yeah, but again, the suicidal threat, see, most of our test book says like 39 CRPC, now it has become 33 BNSS. So, it is mandatory information is for the cases which are below above 7 years imprisonment. So, Supreme Court has decriminalized 306.
There's lot of cases we
309.
get anxiolytics overdose, paracetamol.
So, everything you can make it MLC and keep it. You did not inform. There are certain things did not inform, but it is a MLC case, because tomorrow if she may commit suicide. We had a case, one of our postgraduate committed suicide. Then we had proof. We had a medical legal case, but we are not informed. Why you are not informed? Informed for what? She has put only one incision. If the police tells, she will tell, I did well cooking. Yeah, we informed, we counsel everything, but it has to be recorded. Tomorrow if it is not recorded, then problem will be there.
Thank you.
Thank you.
I have a small doubt, sir, if you permit, regarding that public prosecutor, meeting him before the court evidence, told that there will be prejudice, will get prejudiced when we meet him. Is it okay, is it good that we'll get what are the points of contention from the defense side, so that we can clarify the doubts of the court?
No, what are the questions from defense side, if public prosecutor knows it?
No, it's not like questions, sir. There will be some point of contention where he'll be knowing by previous hearings evidence from other witnesses.
No, yeah, you may be saying, but as far as my knowledge goes, I don't think any public prosecutor would have faced more than 200 murder cases. In your lifetime, you will be facing, you have to guide him. Here we are guiding public prosecutors. For forensic expert, you see what happens is they have got a limited knowledge. They are working in only limited place. You have been to many places. So your knowledge is much bigger. You can help him. See, the other day just I told you, please ask, I wrote there only, please ask this thing, because he is not going to ask. See, we volunteer certain things. When a defense lawyer is pulling our legs, this public prosecutor won't stand up and stand for us. That is the reason I never go. And we had here one lady, I don't want to name her, she used to put more words in her mouth. So we used to fight. That's what I told. It is my opinion. I am not for it. For newcomers, definitely meet public prosecutors, learn certain things. That's my opinion. Aste. In Coorg, that public prosecutor, second court is the DJ, you ask about me, he will tell. They will come, and when we go and sit in the court, other public prosecutors will come and sit and discuss certain cases. We should go to that level, and we have to volunteer also. I will give you a small example. In Mangalore, one case was there, accident near Jyoti Circle, where the person was drunk, a Malayali person, very rich person with a big car, met with an accident at 11 o'clock, admitted to Jyoti UMC, and 4 o'clock they took his blood. 12, 1, 2, 3, 4. So every hour 10 milligram percent comes down. So 5 years 50 milligram has come down, and his blood level was just 5 or 6 milligram in FSL report. So they told it is under the purview of that 30 milligram percent. He has killed 2 people still. Then I was sitting there for other case. I told the public prosecutor, you just hold on for today. Then we gave a test book, we gave all the formulas and and he argued on that basis and got conviction for drunken driving. 2 years or 3 years imprisonment he got. We volunteered. So that became a talk of the town among the public prosecutors. Now the volunteer, not that I have got full knowledge about this thing, but the minute I go to the public prosecutor, their knowledge is limited. The reason I will tell you why they become public prosecutor. Because they are not good in private practice. Who becomes judge? Sessions Court only. This is my experience. I may be wrong, but definitely good lawyers will never become a judge. Correct, Ullas Chetru?
Bad students become lawyers. Bad lawyers become judges.
Yes. That is right. That is a fact. Public prosecutor ಅಷ್ಟೇ. ಒಳ್ಳೆ ಪ್ರಾಕ್ಟೀಸ್ ಇದ್ರೆ ಅವ ಯಾಕೆ ಅಲ್ಲಿ ಬಂದು ಪಬ್ಲಿಕ್ ಪ್ರಾಸಿಕ್ಯೂಟರ್ ಸ್ಯಾಲರಿಗೆ ವರ್ಕ್ ಮಾಡ್ತಾನೆ. They can earn lakhs of rupees per day. Thank you.
Thank you, sir. Thank you for your elaborate discussion on the medical legal aspects.
ಊಟ ಕೊಡುವ ಬೇಗ ಬೇಗ ಅನ್ನ ಸ್ವಲ್ಪ
I request the chairpersons to hand over a memento and a certificate to Dr. Mahabalesh Shetty as a token of gratitude. I request Dr. Kishore Kumar to hand over a memento and a certificate to the chairpersons as a token of gratitude. Thank you, sir. We'll be now breaking for lunch. Delegates, please move. Lunch has been arranged outside the MEU hall. The next session will be intimated soon. The next session will begin at 2:30 p.m.
Parallel sessions are going on in HTT rooms. Delegates who are interested can go and listen to those sessions. Thank you. Thank you.
Recording stopped. At the outset, I should thank the organizers of Foryensicon for having me here. It was sort of a huge get-together for us. I've been in forensic in this community for more than 20 years now, and I've never seen a conference in Kerala or outside where so many professors from forensic have come. They happen to be my friends as well. Kishore serves to be a big magnet, I suppose, because he comes for every conference at Kerala, so we are obliged to come when Kishore calls. So there is the professor from Calicut, Dr. Sujit, who will speak after me, then from Thrissur, Dr. Unmesh, Manjeri, Dr. Hitesh, Kochi, Dr. Lisa, Ajay from Kochi, and I think there are a few of our postgraduate students as well. The topic given to me was about intraoperative bar anesthetic deaths. I'll just limit to intraoperative deaths because those deaths which are thought to be due to anesthesia administration will also fall under this heading. So before we get into the topic, we should know what is meant by this term intraoperative death. It's not deaths occurring while a person is being operated. Largely speaking, the definition of intraoperative deaths will stretch to a period of 24 hours. I mean, within 24 hours of the commencement of the procedure. So on table deaths, most of these patients may not die on the table, but they would, some of them would at least die in an observation room or an ICU in a post-op ICU. But by definition, they also form this subset of unfortunate deaths, which we call as intraoperative or death due to surgical operations. And that term is a very loose term. It could be derogatory to some people, especially surgeons and anesthesiologists. There is still controversy as to whether such deaths should be called homicides, because by definition, a homicide is a death of a human being by the actions of another. So that is another moot question. But this term, all those people who die within 24 hours of a surgical procedure or after being under anesthesia need not die because of those procedures. In fact, the large majority of these deaths, about 80-85% of these deaths, do not die from the surgical procedures or for that matter for being under anesthesia. They die because of the original disease or condition for which they were operated upon. So that is that the disease or injury for which the operation or anesthetic was being carried out is responsible for most operative deaths. And then the person could be operated for a surgical condition, and he would be having a morbid condition which he had before sustaining this injury or disease which made him go under the scalpel. This natural disease which the person might have been having before the procedure gets complicated, most typically a coronary artery disease or something, anything which causes coronary insufficiency because of the stress of the surgery. And that also we include under operative deaths because the person with that condition had been undergoing a surgery, a procedure. So our talk will not focus on those two because that's by my definition. I would limit my talk to the latter two conditions where surgical and anesthetic mishaps cause the death of people. We know, I hope everybody knows about this, the American Society of Anesthesiologists have classified systemic diseases or serious diseases or patients who go in for anesthesia into 5 classes. The ASA 1 grade, those with no serious disease, meaning they may have mild disease, but it's not serious enough to warrant or to make the anesthetist or the surgeon or any people, or even the patient's relatives or the patient himself, think about death as a possibility of this procedural outcome. The other, the second ASA 2 is those who may have a serious disease, but their day-to-day activities are not limited. They have serious disease. It's not mild. but it does not interfere with their daily activities. It could also mean perfectly compensated patients who might be having result in death. And the last, the ASA5, the most severe systemic disease is a person who is expected to die anyway within 24 hours, whether you operate him or not. So the focus of this talk will exclude ASA 4 and 5, and we are going to discuss about cases which in which people die, which leaves a lot of people scarred, not just the patient's relatives who might have lost a dear one, but we must also spare some thought for those qualified medical professionals, competent people who have put in so many years of training, also suffer. We have to keep, when we speak about intraoperative deaths, the general talk is about finding out negligence, whether the doctor would have done something differently to say, and everybody is wise on hindsight. But we have to understand that surgeons and anesthesiologists have suffered badly because they lose their patients, and that's not entirely because there is a legal fight which awaits them. It is just that they empathize with their patients, they grieve also. So with that in mind, this talk is not about medical negligence in operative deaths. I am dealing with the pathophysiology of intraoperative deaths. And when I say pathophysiology, I'll be just mentioning gross anatomical, morbid anatomical conditions to pick up at autopsy, like rupture or injury to a major organ or vessels, which we can easily pick up during autopsies. My talk centers largely about operative deaths or deaths after medical procedures where the autopsies are either negative or obscure. Here I make a distinction between negative and obscure autopsies. In which negative autopsy gives you nothing. All investigations, gross and microscopic toxicology, everything is normal. Whereas in an obscure autopsy, you could get pulmonary edema, you could get vascular organ congestion, but these findings are inconclusive for you to form a definite opinion. And you may have to think about what went wrong with the patient, not the cause of death, rather how he died. What made a person die is the cause of death. How that cause of death operated is the mechanism of the abnormal physiology, which do not leave behind telltale signs for us to pick up at autopsy. So we are doctors, we are not policemen, we are not judges. We know, we study physiology and we study pathology when you talk to people who have been doing cases on such unfortunate people. So ultimately the question is this. If you want to say that, if you want to call or give some credence to the title of my talk, intraoperative deaths, meaning deaths caused because of operation, you have to answer this question. On a road, when somebody, in road rash case for example, and you don't tell the other person is responsible for your myocardial infarction, you, for example, and you don't tell the other person is responsible for your myocardial infarction, you were an ASA 4 of mortality and morbidity, enumerate, you get a number at the end. Of mortality and morbidity, enumerate, you get a number at the end. So looking at the number, you say whether you tell the person objectively. People ask a person objectively, people ask you those questions, relatives ask you those questions. Etra shadaman, in Malayalam they say etra shadaman chance on the rakshavada. What is the percentage of probability that you might escape? It's a very common question people ask. They actually need a figure out of you. You would say it's risk. People say you operate under high risk. People say you operate under high risk anesthesia. As far as I am concerned, there is only one person taking the risk. That is a patient. The surgeon operated under high risk consent. The anesthetist gave thing which affects your consciousness, an increasing or a thing which affects your consciousness, an increasing or a decreasing Glasgow coma scale adds to this. The respiratory status, the cardiac status, the ECG, blood pressure, pulse rate, your hemoglobin, your white blood cell count, and your metabolic parameters like urea, sodium, and electrolyte parameters. There are 12 of them, the physiological parameters in the POSM score, as well as 6 operative factors, which include whether the surgery is an elective one or an emergency one. The complexity of the operation, meaning how much time it will take. It will take hours, or this is a procedure which lasts just an hour. Multiple procedures, multiple anastomosis is being done, multiple body cavities being opened. Severity of hemorrhage expected during the procedure. Whether it's a sterile surgery like a thyroid surgery or a hernia, where you don't open hollow viscous, where you breach the where you don't breach barriers between a bacterial colonized area and a sterile one. And if you're operating for malignancy, whether it's a malignancy which has spread to other places, when you do even a palliative malignancy surgery. So these are the factors over which you get to a score, and each of these factors are given weightages 1, 2, 4 and 8. You can just Google it, you'll get how Possum score severity is calculated. But this come from the Scottish audit of surgical mortality, and they are pretty accurate. They've backed it down with retrospective studies as well, and they found out that the predictions were fairly accurate, more than fairly accurate. So each of these factors are given some numerical numbers, and the total physiological and operative scores. The last one, if you have the operative factor 6, the maximum score is 24. Not all the factors are given this much amount of scores. The maximum is 88 and 44 respectively, and then a logical regression is done, and you get a pretty accurate figure about what you can tell to the patient or relatives about the expectancy of death happening as a part of the surgical procedure. So that's a Possum score which you can use. And then we'll come to operative deaths and their causes. Well, I said it's not a list of, this talk is not going to be a list of conditions where you get these morbid anatomical findings. But generally we are blood detectives, we look for bleeding. You look for either hemopericardium, you look for either of these cavities, pericardium, the pleural cavities, or the peritoneal cavity or the pelvic cavity. You look for blood and assess that it is, all this blood is antemortem, which again is a fallacy. You could have postmortem leakage into these cavities as well. So all that amount of blood which you see at autopsy may not be antemortem, it could be postmortem seepage as well. But it gives you a fair idea whether the blood was clotted, and all will give you a further idea about at least the existence of a non-arrested bleeding from an organ which got injured during surgery. We have seen cases where a central line was attempted blindly, not under UST guidance. A simple cannula being put, instead of getting into the subclavian vein at a convenient angle, just tore through it. You know the subclavian vein is a horizontal vein. It's not anti-gravity, it does not do anti-gravity, just a conduit vessel. It's very thin walled, and it can easily lacerate. So if you're not puncturing the subclavian vein at an angle where it is safe, you could just tear through the lumen, and the person just loses blood like as though you tip over a bucket full of water. It is just blood flowing like that, and the person will be totally conscious. It's just the initial stages of the procedure. You will find hypotension, and then you may attribute it to idiosyncratic reactions to your pre-medications. I've seen more than a handful of cases where other conditions could have been there for explaining death, but death happened sooner than later because of an inadvertent subclavian vein puncture. Another case was about a hernia repair where you do the darning, you take the first bite from the pubic tubercle. It's a curved needle which you use, and I have seen 2 cases where the needle went deeper down than it was intended and just tore through the femoral artery, with concealed bleeding into the limb, and the person showing pulselessness towards the end of that post-operative day, having lost significant amounts of blood into the facial planes of the thigh. So femoral artery puncture during hernia repairs, you don't expect that. Or it could be vasovagal deaths, as what happened in a colonic perforation while the person was undergoing a colonoscopy, and that was from reflex cardiac inhibition. The patient just looked to be asleep. There was no pathological, a total negative autopsy with no pulmonary edema, nothing. A person just went as a switch got turned off. tracheobronchial ruptures during bronchoscopy especially, this I have not seen, but I have read about it when those days you used to have those rigid bronchoscopes for bronchoscopy. And there could be excessive bleeding, not particularly due to an injury to a specific vessel, because of preoperative anticoagulation drugs which the person might have been taking. We would stop them before surgery, but the actions of those drugs need not stop. His homeostasis and his body balance would have been tilted in favor of a bleeding tendency. So there could be sepsis, like, you know, it's a gangrenous bowel which you are operating, or a strangulated hernia in which the person is already having bacteremia, or you could even say septicemia while you operate. And in malignancies, there are malignancies which result in paraneoplastic syndromes as well, where you could get massive bleeding, more than what you expect. Obstetric complications, especially a person who has undergone abruptio placenta, then needing cesarean, would bleed because of the DIC caused by the abruption. A person who has impaired liver function prior to the surgery will of course be having disturbed or altered clotting in bleeding time, as well as bleeding disorders. So I don't know, but local surgeries, do they do bleeding time, clotting time before a local surgery now these days? I'm not sure. So a person with a bleeding diathesis could excessively bleed from sebaceous cyst removal also. If it is up to the standards to be established for what a proper pre-anesthetic checkup would be, should be left to those people who should not be left to forensic people. But the standard of care expected in a pre-operative assessment is another topic, and I don't think we should delve into it much. So all know, and MBBS, even we teach MBBS students about primary, reactionary and secondary hemorrhages. Primary hemorrhages is the bleeding which happen at the time of your surgery. Surgeries will bleed. Reaction is happening within first 24 hours with suture slippages or slough being removed, or a bleeding vessel which could have been arrested by the use of a mosquito. When you finish the surgery, there won't be any bleeding, but the primary aldosteronic response and a rise in systemic blood pressure in the first 24 hours after a surgery might dislodge the temporary tamponade effect this mosquito had over the bleeding vessel, and the person may start bleeding. Secondary hemorrhages, we know, happens after 24 hours of a procedure. It's usually due to infection, sloughing off of leakages and other things. So all this will be evident. If it's bleeding, you will see it at autopsy. Like I said, my talk does not concentrate on those easy autopsies where you just open a body, see some blood attributed to the source, and then you finish. So I'm talking about altered physiology, and I would like to focus on 2 or 3 very normal scenarios, and this just the objective is to just raise awareness with amongst forensic people about how you should approach. The other complication following surgical procedures is embolism. We know. We are worried about fat embolism, especially when a person has got fractures, especially of the long bones, but other injuries as well as surgeries on other areas can also result in extensive soft tissue injuries or acute pancreatitis. Burns, we know that even mastectomy, your breast is actually a lot of fat tissue. Spinal and orthopedic surgeries, and now liposuction. We had some media reports now about fat embolism and liposuction. It's very dangerous surgery, which though employed in cosmetics. Air embolism, especially on those areas above the heart, even if the patient is lying down. So all neurosurgical procedures, neck surgeries, including thyroid surgeries, total panel nutrition sites, and also when you put in a fistula for your AV fistula for dialysis. From all these areas, air embolism can happen, and air embolism can happen during a surgical procedure as well, through the tubings. If you're not keenly looking at whether the IV fluid the bottle has got exhausted or not. Amniotic fluid embolism, I think every forensic pathologist having a reasonably busy practice would have come across it, or at least a few of deaths being attributed to amniotic fluid embolism. Though I would maintain a healthy distance from making a diagnosis of amniotic fluid embolism simply by looking at the histopathology and seeing some fetal scans. Logically speaking, it's possible for some amniotic fluid, because the woman, the mother, has got a huge hole in her cardiovascular system and the placenta moves out. So it's only natural that a few fetal scans get into the maternal circulations. And amniotic fluid embolism, as we all know, is different from amniotic fluid embolism syndrome, where it's basically a systemic allergic response to it. The problem is not a right ventricular outflow tract obstruction or ventilation perfusion mismatch. It's an immunological reaction, but I believe a lot of deaths are attributed to amniotic fluid embolism, where it could be actually due to some physiological reasons, as we shall see later. Fibrocartilage embolisms have been documented and published following open reduction internal fixation surgeries. Suture embolization to left anterior descending arteries have been documented following mitral valve replacement surgeries, and catheter tip embolizations have been reported following CV line catheter tip blockage or even PTCA, catheter tips getting broken and embolizing the left anterior descending artery. So these are, again, if you get all those things at autopsy, these are all wonderful morbid anatomical findings for you to come up with an opinion. And then we'll come to anesthesia mishaps. So 20 minutes more, sir. Okay. So it could be like, it's an age-old story, going to the days of Big Cat, where mode of death was asphyxia, syncope and coma. We still look at those three major systems: problems with the heart, problems with your brain, and the problems with your respiratory system. See, we were having a discussion today about whether deaths under anesthesia should be intimated to the police. It's my opinion that all deaths under surgical procedures should be evaluated properly, and an autopsy should be done. Whether it's ideally, it should be, if there are no allegations of negligence, there should be a hospital pathology or pathological autopsy done. And ethically or even legally speaking, it's a man who was not in control of his life when he died, when he is under anesthesia. Somebody else have taken the custody of his activities prior to his death. It is a form of custodial death, though we would not use it within the same meaning, but it should be evaluated properly. And I will come to that in the last slide also, why I feel so. We will come to cardiac arrest. The first subset, ASA 4 and 5, we have left out, because we are not talking about people with severe heart disease who died during a procedure. We are looking at cardiac arrest as a part of the stress of anesthesia, and also drugs which can precipitate cardiac arrest, drugs which can produce tachyarrhythmias in a hypoxic environment where the heart is already under stress, and you could be having hypoxia which sensitizes the myocardium for tachyarrhythmias, and neurogenic arrest where the death is so rapid that it can't be cardiovascular. It's a sudden neurological death, mostly attributed to vehicle inhibitory effect on the heart. You call it vehicle stimulation. I have two cases in my career, where one of which happened very recently, about 1.5 years back, where a woman had come for a postpartum sterilization surgery. A busy day, they were planning about 20 of those surgeries that day, and this lady was subjected to local anesthesia for insertion of a Phillips ring. and they were not successful in putting the ring, so manipulations had to happen. They lifted the head and they brought down the head end of the patient to such an angle, and they tried to hook out the fallopian tube and do a procedure, and the patient immediately collapsed. That's vagal inhibition happening. There could also have been a substratal hypoxia, because the head end being brought down to such a low extent, you could have pressure on the diaphragm, which produces defective breathing and creating hypoxia, which sensitizes the heart to tachy or even bradyarrhythmias. The other was a case where the anesthesiologist was in a hurry to finish the case. They usually are, because for obvious reasons and not so obvious reasons. He was actually reversing the procedure when the procedure was not being done, or not completed properly, and the doctor was handling the bowel loops much earlier into the procedure, or if you want to call it either way. Patient appreciated pain because of the analgesic effect having worn out, because anesthesiologist had started reverting the anesthesia, and the person died on the table because of reflex vagal shock. It's on the ECG monitor, it's just 1 minute the heart working normally, and the other 2 or 3 or 10 or 30 seconds of bradyarrhythmias followed by cardiac arrest. That's typical vagal inhibition. So Snehal was talking to me about a case in which he did autopsy when a local anesthesia was given, and the person developed tachyarrhythmias. The only possible explanation, as diagnosed by clinicians even before the death, was that the local infiltration went directly into the blood vessels and precipitated a tachyarrhythmia. We will come to that later, but I just want to focus on hypoxia, because it's all too often very common that you see that you look at the case sheets and you see a person undergoing a procedure all right, and then what is written in the case sheet is that the patient suddenly desaturated. So there is a precipitous fall of SpO2, the partial pressure of oxygen in blood, and it could be precipitous. The other possibility is that you are not monitoring the person properly for you to look and see and get shocked by a sudden fall in SpO2, where the person might have been having a gradual fall in oxygen saturation over a period of time. So that can only be picked up with meticulous monitoring of the patient during anesthesia. And again, we'll come to that later. I will talk about again factors that are outside the body. It could be failed intubation. This case happened about 15 years back. A lady, she had an implant in her forearm. She wanted it taken out before her retirement. The doctors there, they were working in not so well equipped hospital, at a government hospital. They said, "Madam, please go to the medical college," but she was very insistent that she got that surgery done in the hospital where she was working. And she was intubated. She never recovered. At autopsy, this lady was huge. Her body was actually, you could say, flowing outside the autopsy table, hugely obese. One of the reasons why they also asked the lady to go to a better center. And when you opened the body, her stomach just popped out, so full of gas. We thought, how could a person having consumed so much food ever be subject to an elective surgery under general anesthesia? But her stomach was empty, it was full of gas. And there was this telltale sign of the esophagus, the tube having gone into the esophagus with an induration and loss of epithelium at the level of the esophagus where the tube should have been if it was positioned properly in the trachea, with the absence of the tube having gone into the trachea also. That was also there. Could be faulty apparatus. These are, we can't do an autopsy and find these things out, but an investigation of an operative death should not be focused on the dead body or the medical cause of death. There could be other reasons as well. Reasons outside the competence of the anesthesiologist, so to speak, which may come under corporate negligence. A faulty apparatus, inexperience, I will come to that later. An overdose very rarely happens, unless it is never. In fact, a spinal anesthesia overdose is almost very rare, unless you have some ascending spinal anesthesia problems. anesthetists, these are trained people, they know what the right dose is. Very rarely does somebody die of an overdosage, but for completion's sake, let it be there. Blocks in the air passages either through blood, mucus or foreign body, real foreign bodies to ridiculous ones as claimed by forensic pathologists in our state. At least a few of those cases I can remember, where a gauze found in the respiratory tract at autopsy was thought to be the cause of death, whereas it was just the padding around a tube. You could have a situation where a person was operated under light general anesthesia with no tube put in, but the patient has got respiratory secretions as the procedure is going on. Patient desaturates and the anesthetist wants to take control over and switch it on to a proper general anesthesia. So you could do a throat section, but you could have secretions in the tracheobronchial tree. If that is the case, with no proper sucking out of those secretions out of the tracheobronchial tree, you put in a tube, you push all those secretions and blood into the periphery, and you lose about 50-60% of the alveoli. And there's no way you can get around that. So a delayed intubation or an improperly secured airway, these things don't happen at the start if you put in a cuffed tube. But like I said, there is a small subset of general anesthesia cases where you don't always operate after intubation. It could be a light anesthesia. When later switched on to an intubated anesthesia, these things can happen. Faulty meter flows, meter reading wrong, or empty cylinders is a fragile intubation, we already told, and as well as chemical pneumonitis and severe airway spasm because of gastric acid aspiration, not necessarily gastric contents, which is unlikely for a person who is prepared well for anesthesia. I'm not talking about emergency surgeries here. The other thing which can happen with no fault of the anesthesiologist and still be termed as an operative does is adverse drug reactions. This could be pharmacological type A ADRs, which is just extension of the normal pharmacological reaction of those drugs. Two idiosyncratic reactions which are basically bizarre and totally unpredictable incidents which can happen in a person to a therapeutic dose of the drug due to other mechanisms. So with regard to the type A pharmacological ADRs, anesthesia is not a single drug procedure. You would have pre-medications, you could have a relaxing drug, you could have an analgesic, or you could have antihistaminics, or some people may even have proton pump inhibitors or H2 receptor blockers. And it's published and well documented that if you have a patient with polypharmacy of drugs exceeding 5 in number, there is almost a 50% chance of a type A reaction happening. Am I distracting you? Because, okay. Yeah. Okay, the type 2 could be, type B could be an idiosyncratic reaction, where the dose is correct, the patient is correct, but it's totally unpredictable and you get bizarre kind of reactions. The commonest things reaction which you could see is a immunological reaction gone wrong, is anaphylaxis. Anaphylaxis can happen intraoperatively as well. So it's not always that anaphylaxis happens in a conscious person. In an intubated patient itself, you could have anaphylaxis, a new drug being injected, or G6PD deficiency or other enzyme deficiencies which could unmask a hemolytic process happening, or sickling crisis during anesthesia, or cell receptor damages like the neuroleptic syndrome or malignant hypothermia, which is basically your muscles getting burned up because of an enzyme problem, an autosomal dominant disorder, which involves calcium influx into the muscles. The patient goes in for hypothermia and goes in for sympathetic overactivity as well. Or it could be drug-induced multifactorial genetic conditions like halothane-induced acute fulminant hepatitis under anesthesia. So I'll focus on this group of patients, and on two conditions purely physiological, which I think every forensic pathologist and every anesthesiologist should be aware of. In fact, these two are taken from an article written by a retired professor of anesthesia from Madras Medical College. So I'm talking about two conditions which can happen leaving behind no anatomical abnormalities at autopsy. One is a chemical sympathectomy following ascending spinal anesthesia, which is not intended to go to that level, and a normovolemic pulmonary edema in preeclampsia conditions. A lady with borderline hypertension suffering from what looks like a cardiac disorder and then finally leading to death. The ascending spinal anesthesia situation is given on the left. I hope at least a few of you might have encountered this situation. The typical history is that of a person on a table, one whom spinal anesthesia is given. The patient is turned supine, a wedge is kept, and even before the incision is put, there is a sudden fall in saturation. You will find in the case records that the anesthetists have written that there is a sudden desaturation. And intervention is done, and intermittent positive pressure ventilation is given through face masks or even intubation. And saturation, whatever you do, it becomes intractable. The patient never responds to your aggressive treatment, and a cardiac arrest happens. The patient could not be revived. Sometimes they get revived and they die after within 24 hours or so in an ICU. Have you seen this scenario happening as spinal anesthesia being done and the patient developing a cardiac arrest even before the procedure is being done, has started? Okay, what happens if this has happened, if an ascending spinal anesthesia has happened, what happens is there is chemical sympathectomy. It's in chemical sympathectomy, there is diminished venous return. Because no blood is coming back to the lung, it's all getting pulled down due to the vasodilation at the periphery. The heart does not have any, it's nearly empty. That's why you do whatever you want. Blood is not coming to the heart for you to correct this desaturation. And it is so catastrophic that you term it as amniotic fluid embolism, especially if it's midway. The ascending spinal anesthesia need not happen at the beginning itself. It could happen within 30 or 40 minutes of the procedure being done. So amniotic fluid embolism is typically encountered in deliveries just after the baby is delivered and the placenta is gone. So that's about 30-40 minutes into the procedure, 30 minutes into the procedure. And that is about the same time it happens for an ascending spinal anesthesia to produce total chemical sympathectomy. And if you find a few fetal squams in the circulation of the mother, it's very tempting to attribute that death to amniotic fluid embolism. I'll tell you what happens. It's a normal pharyngeal steel incision which you put in for the LSCS. The dermatome targeted is about the T11 level. Okay, the T11 dermatome is the dermatome targeted for cesarean section. However, the anesthesia is aimed at, the spinal anesthesia level is aimed at somewhere around T5, T6. That's because the afferent nerves from the intestines will be handled by the gynecologist during the LSCS surgery. So those come from the greatest planning nerves goes from T6 to T10 and the lessest from 10 to 11. So you would want to get the spinal anesthesia high up to a level of T5, T6 for bowel efferents not to reach your brain to have a reflex arc working. So what happens is that it's another factor that the women have thoracoabdominal breathing, especially when they are pregnant. It's the thoracic which is going to move because the abdomen is full of the uterus. So I've seen cases where my friends have talked about anesthesiologists giving spinal anesthesia and then moving on to another patient giving BC anesthesiologist. But what you should be doing is you should be waiting and looking for the thoracic movement because women breathe thoracoabdominal. You watch for the thoracic movements and you find slow desaturation happening. So you ask the patient you put your finger underneath and ask the patient to grip tightly on your finger. And then if the patient is able to do that, if the grip is tight, the brachial plexus, the thing starts from C5 to T1. So if the patient can hold your finger tightly, it means that it has gone up from T5, T6, but it has not gone above T1, because if it goes above T1, the patient won't be able to grasp your finger tightly. So if the grip is tight, it has gone up, it has gone up. It has gone up to a level which should never intended to, but it's still below T1. And if the grip is slight, watch for the movements of abdomen. Now abdomen moves with the diaphragm which is supplied by C345. And if the abdomen is moving properly, it means that it has gone up, it has gone above T1, it has reached up but below C5. Okay, C345 is phrenic nerve. If the abdomen moves properly, it's highest for cervical anesthesia, but it is still below C5. So if the abdomen movement is okay, these are all warning signs. The person is actually having, you need not go into arrest, but there is vascular pooling happening because of high sympathetic block. And if it is sluggish, it means that your spinal anesthesia is ascended above C5 and the surgery should be, the anesthesia should be shifted to assisted ventilation and if necessary to intubated general anesthesia. Now the point is, if you look at case sheets in cases where people have died, do you see this monitoring being having taken place? Because one of the defenses an anesthesiologist can take against ascending cervical spine anesthesia, because I said it's completely physiological and it's not going to leave behind any anatomical abnormalities at autopsy. So if these procedures have been followed, if there has been a recordical document of the anesthetist having checked the possibility of ascending spinal anesthesia throughout the procedure and documenting it in the case sheet, that's a sure bet insurance for the anesthetist against this proposition that a person could have died of chemical sympathectomy. Did I get my point across clearly? Yes? So we could talk about another situation here. Sir, I'll take 5 more minutes. That's okay, sir? Okay. The other scenario is a person is given general anesthesia or spinal anesthesia. This patient is somebody with pregnancy-induced hypertension, or you may call it preeclampsia or borderline eclampsia. Procedure happens. Before the end of the surgery, there is again desaturation. At the same time, there is evidence of pulmonary edema. A diagnosis of pulmonary edema is made, and in spite of diuretics and all supportive managements for pulmonary edema, the patient dies. But because this is acute left ventricular failure, this pulmonary edema may be accompanied by an initial fall of blood pressure as well. And if the anesthetist doesn't pick up this thing, and if he tries to overcome this fall in blood pressure by having IV fluids, this is pulmonary edema at its beginning. You are pushing the patient over and possibly looking at an intractable pulmonary edema which is not amenable to treatment. So what happens is, we should know the physiology at the lung. As you know, the lung has got different mean arterial pressure. The mean arterial pressure is the diastolic plus 1/3 of pulse pressure. Pulse pressure is systolic minus diastolic. So let's take a person's BP to be 120/80. It will be 80 plus 120 minus 80, 40 by 3. It will be 90/93. The usual pulse pressure, mean arterial pressure will be about 93 millimeters of mercury in a normal person. Whereas the mean arterial pressure in a lung is going to come from the pulmonary artery, which is getting blood pumped by the right ventricle instead of the left. So the mean arterial pressure in the pulmonary circulation is 15 to 20 millimeters of mercury. And the opposing force, there are two forces which determine whether an organ gets edematous or not. It's your oncotic pressure versus your hydrostatic pressure. The hydrostatic pressure inside the pulmonary artery is the mean arterial pressure, which is about 15 to 20. And you have about 24 grams, which is throughout the body the same, the oncotic pressure. So in normal condition, because of this difference, we never get pulmonary edema. That is because of the oncotic pressure being greater than mean arterial pressure in the pulmonary circulation. So when in a normal person, due to some reason or the other, there is a rise in left atrial pressure, which gives behind a push back into the lungs, it goes up. So if it's greater than 15, now you have a negative intrathoracic pressure acting to push blood into the lung. So that 15 plus 8 to 9 makes it more than the 24 of the oncotic pressure. And why we are saying this is that a person could get pulmonary edema without fluid overload. This is just abnormal physiology happening, and especially you have a condition like severe preeclampsia where there are two problems to add to this. Is that there is increased capillary leak, which makes the patient prone for pulmonary edema, and also the patient has proteinuria when she has preeclampsia, which makes her plasma oncotic pressure go down. So that's a double whammy with no fluid overload, pulmonary edema developing, the doctor feeling that the pulmonary edema is due to acute left ventricular failure, pushes in fluid, and then rushing in intravenous fluid during surgery, you are going to precipitate fatal pulmonary edema, which is not going to get relieved with diuretics, because increased leaking of the capillaries and decreased plasma oncotic pressure is not going to be relieved with diuretics. So being aware of this condition, that is what may help the patient. I think I'm shooting over a bit, so okay, I hope this is just an explanation of what I said in the previous. So I'll just share my experience about 4 or 5 cases, some of which I have already mentioned. The esophageal intubation case I already mentioned. Vagal arrest in handling intestines and fallopian tube we have already mentioned. Tube removal and reinsertion happened to an unfortunate patient who had massive Lefort's fracture, facial fractures. The patient needed 2 approaches for his surgery. So what they did was that initially they did an orotracheal intubation and did surgery on the nose. And when they completed that with the patient under, they removed the tube and tried to put a nasotracheal intubation, failed. That was it. The patient they just lost the patient. Because of the surgery done to the nose made it more difficult, the air passages. You could have thought in hindsight that they could have did a tracheostomy, put the tube there, did the surgery and then finished it later, but everybody is wise on hindsight. And intravascular injection was another unfortunate case where we did an autopsy. A person was given general anesthesia. The surgeon, for some reason or the other, maybe to control bleeding at the site or a posterior pharyngeal wall surgery, while the patient was under anesthesia, gave local anesthesia, which was liquidine and adrenaline, and the patient's blood pressure, which was 120/80, shot up to 260/140. That could be nothing else other than adrenaline. No drug shoots your BP from 120/80 to 260/140 in a jiffy. So that is intravascular injection of adrenaline. The Moynihan, we did an autopsy 1 month back, is an aberrant right hepatic artery, you know, the Calot's triangle at the base of the liver, where the cystic artery should be cut in a cholecystectomy surgery. But you have this abnormal tortuous right hepatic artery which gives us the cystic artery, which is mistaken for the cystic artery and removed, and instead of the cystic artery they cut the right hepatic artery. And you know the right hepatic artery is an end artery. If you ligate it, you are going to lose the right lobe of liver. A hip screw in the urinary bladder was a hip screw which went through the acetabulum, pierced the urinary bladder, and was found on a post-op X-ray to be the nail inside the urinary bladder. They did a second surgery, did it through cystoscopy and removed the nail, but the patient died. And Ajay reminds me of a case when he did a TLP, when undiagnosed tachyarrhythmia during surgery resulted in a person's death, and at autopsy we got an undiagnosed pheochromocytoma. So this is where I started. There is this aftermath. I have one very personal opinion about who should do an autopsy in a case of alleged medical negligence. Like custodial death, we drew the parallels earlier. Police and doctors are supposed to help and serve and protect. So when there is an allegation that there is a death under custody, it's a state which comes under suspicion. Those people who were sworn to protect have now been accused of taking a life. Likewise, modern medicine is supposed to save people. So when there is an allegation that there has been a medical failure, there has been a medical negligence, for more reasons than one, modern medicine stands on the dock, science stands on the dock, and if such a case comes for autopsy, the senior-most people in the department should be doing that autopsy. And there should not be any co-pilot syndrome where a professor is clubbed with a junior assistant professor or a senior resident to do a team autopsy where who knows, everybody knows whose opinion will prevail. And if you have forming a team, it should be of equal people. If possible, I would say it should be made mandatory that anesthetists and surgeons should be made a part of the team which does an autopsy on a post-operative death, because most of the forensic people have got no idea about how a post-operative appearance look like, and we can make horrible mistakes and maybe expose our ignorance as well before our clinical colleagues. That's better avoided, I suppose, because people think that we are very knowledgeable. So the autopsy should, if possible, be done by a team which is outside the hospital where this alleged medical negligence has happened. So justice should also be done, it should be seen to be done, neutrality should be seen to be there. So it's always preferable that it's a multi-disciplinary team which does the autopsy, a team comprising of peers of equal stature, senior, and possibly if the team comes from outside. And lastly, trauma rehab of anesthesiologists and surgeons. We are capable surgeons, we are capable anesthesiologists. We have a new CBME curriculum, a postgraduate curriculum, and CMEs like this where we don't target this group. It is severe post-traumatic stress for people who lose their patients under anesthesia. There may be very good surgeons and anesthesiologists who feel they are to be blamed for taking the life of a person. They feel they are not fit to do the job. And Lisa, we all know there are at least a few of those who never return to OTs after they lost a patient. We have almost nil support, professional support existing in India in any official or what do you say, planned out areas where we take care of our own people who live under the trauma of having caused the death of their patient by an operation. That's all. I thank the conveners of this meeting, Kishore especially. I take special mention of Dr. Sebin, who is an assistant surgeon in General Hospital, Kanjirappalli and Pala, working in Kerala. He gave me all those articles. He put so much pressure on me. 45 latest articles from various journals for me to study upon. And then Professors Ajay, Hitesh, Lisa, Sujit, Kishore, all my dear friends, thank you very much. I am happy to take questions.
Thank you, Dr. Krishna, for giving such an explanatory about all the possible causes of intraoperative death. It has been really eye-opener for each one of us. Thank you so much. If anybody is having a question, please you can proceed.
Thank you, sir. Yes.
We also have anesthetists as well as forensic people doing together.
Yes.
But having this much of knowledge is paramount from our side, and half the knowledge I don't have, to be very honest. So it was an excellent presentation.
Thank you, thank you.
As far as the forensic medicine is concerned, it went little about, but as far as anesthetists, they are very happy to hear you. These two are anesthetists. Definitely they will call you.
Okay, sir.
In a nutshell, if I have to say, many of these are like golden words, especially when you talked about whatever is the cause, but we need to evaluate it.
Yes, ma'am.
If today we are taking shortcuts, we are taking shortcuts on a whole host of things, jumping to conclusion, thinking of it, approaching with a bias, preformed decision making already even before you want to do something. So I think we all need to take a step backwards and look at the big picture. Where have we gone wrong before? Because each of us have our own mistakes that we have made, and each of that, instead of putting under the carpet, if we are to spell it out, these are the milestones, and if they are done as a checklist, it will prevent. So I think there is a huge worth of resource that you gave us through that. So it's worthwhile reflecting upon it. I really appreciate it.
Thank you.
Thank you.
Sir, as a physician, it was a very great talk to listen from you. One more thing I want to add is post laparoscopy, when there is PCO2 is in this one, we have always seen we have seen certain patients with severe bradycardia, heart rate going up to 30, 40. When the patient comes out of the anesthesia, the reason being that during anesthesia they would have given glycopyrrolate, but later the heart rates would have dropped to 30, 40, and we have seen 1 or 2 cases where sudden patient goes into heart rates of 30 also.
Yeah, they give drugs with a reason, I suppose. So when things go out of hand, you know, it's just. I'll just tell you. I had a court appearance the day before I came over here. It was a case of a person with pelvic fractures having died of pulmonary thromboembolism and deep vein thrombosis. It's a road traffic accident case, and I was cross-examined by the defense lawyer. Very rare these days in road traffic accidents case as to whether this was a medical negligence case. Person dying of this person just had he had massive pelvic fractures. And I said, well, pulmonary thromboembolism and deep vein thrombosis are reasonable complications of any person who has been immobilized. So the decision as to whether a person should be given blood thinner drugs or blood clotting drugs in a person who has bleeding is a product of judicious mind application by an expert who is supposed to do that. When these questions are put to us, to anesthesiologists like me, I'll take his words. I said, I'm not the guy who should answer this. I was interested in trying out the cause of death, finding out the cause of death. But I certainly believe I have to respect, this is very personal, I have just respect for two kinds of people in medicine. One is the anesthesiologist and the other is the pathologist. Okay. These people are magicians. They take you to the brink of death, and that's wonder happening every day. About 20 million they say every year surgical procedures. So nobody takes a professional risk as much as the anesthesiologists do. And I know at least a few people who have been utterly devastated by what happens when a person dies under their watch for no fault of theirs. It's mostly the surgeons would put the fault, finally they will say anesthesia, and these people take the brunt of all these things. They give drugs with a reason, and I think we should go by it, unless some gross negligence like the wrong drug is given or an empty cylinder like that. For the kind of risks these people take, I think they should be judged with a different compass altogether, rather than the compass of we people who have the comfort of forming opinions. That's what I think.
Thank you very much, sir, for your extraordinary talk. I am sure that not only the forensic experts, even the anesthetists and the physicians, all are benefited by your talk. And thank you so much for your talk, sir. Thank you.
Thank you very much, sir. I would request the chairpersons to felicitate Dr. Krishnan B. with a memento and a certificate. Thank you, sir. I request Dr. Kishore Kumar, sir, to... Alright. I invite Dr. Veena Vaswani, ma'am, to felicitate the chairpersons, Dr. Shankar and Dr. Arvind. Thank you very much, ma'am. I now invite